I'd like to say hello and to welcome everyone to the Falmouth Forum on Opioids and Overdose, organized by the Center of Biomedical Research Excellence, or the COBRE on Opioids and Overdose, the Migrant Communities Project Initiative, and co-sponsored by Cape Cod, Cape Verdean Museum, and Cultural Center, the Cape Verdean Club of Falmouth, and the Portuguese American Association of Falmouth. My name is Miguel Muniz. I'm an anthropologist at the Center for Research in Anthropology at Esquite at the Lisbon University Institute. And for the past 2 years, I was a visiting professor and scholar at Brown University's Portuguese and Brazilian Studies Department. I'm also the director of the Migrant Communities Project Initiative at the COBRE and a native of Falmouth. In fact, signing in from my mother's house in Falmouth, where I grew up. I will be your moderator for today's forum. On behalf of the organizers and sponsors, I would like to thank the panelists and those making presentations today, and welcome the public to this event. I'm looking forward to learning from international and local experts involved in responses about the work of researchers and law enforcement, international and local experts involved, and the stories of the lives of those who've been most directly affected by the opioid crisis. Through these conversations, we hope to destigmatize opioid use disorder and medical practices around its treatment. We also hope to educate the public on some of the challenges faced by those working to improve the situation and provide perspectives based on scientific research and evidence-based best practices towards solutions that help to save lives and reduce harm to individuals and communities. Prior to the COVID pandemic, the opioid overprescription caused the worst epidemic in 100 years and greatly complicated efforts to respond to the crisis. Indeed, over the past year and a half, some parts of the country have suffered higher rates of accidental overdose fatalities than was caused by COVID. As the state and region begins to emerge from the public health and safety measures intended to mitigate effects of the coronavirus, one goal of the forum is to also help place a spotlight back onto the opioid epidemic. Most people on Cape Cod and in Falmouth are well aware of state and national news reports, or for example, the HBO documentary Heroin, Cape Cod, USA, and their depictions, sometimes sensational, of the tragic local impact. No doubt the Cape and this town have been hard hit by the opioid epidemic, but this is of course not exclusively a Falmouth problem. It is a state, regional, national, and global crisis. Responses and attempted solutions are complex, implicating efforts to limit the supply and effect of harmful and frequently fatal illicit substances like fentanyl, and has prompted an evaluation of approaches to the prescription of medication and practical efforts to reduce harm caused by opioids. The limitations of our healthcare and insurance system, of a lack of affordable housing, are also part of the complexity of the problem, as are societal attitudes toward criminal justice and punitive measures as a failed deterrent to opioid use disorder. This all hurts the individual suffering from the disorder, of course, but can also take a harmful toll on family and loved ones and their communities, and drains economic and social resources. Deep reservoirs of family love can be exhausted, and the challenges, frustration, and often anger expressed by those who struggle to help family members or themselves who are impacted in local communities are often mirrored in societal attitudes that can make evidence-based solutions difficult to implement. It is a problem that obviously affects everyone across all demographic, racial, and class categories. But as with all healthcare crises, the burden most often falls upon the most vulnerable, including the poor. It is also cross-cut with overlapping and co-occurring factors, notably race. As a result, efforts to reduce harm caused by the opioid crisis is also an effort to promote social and racial equity, especially as drug policy and the criminalization of addiction have a long history of being used to further marginalized vulnerable populations, including African Americans, migrants, and other historically underrepresented groups. There are no quick and easy solutions, even as a growing body of research and practical experiences and experiments in the US and other notable parts of the world point to some areas of consensus toward best practices. We will hear about some of these approaches today. It is also important to recognize that this forum is being presented as part of a long history of conversations, public hearings, workshops, and action plans taking place in Falmouth and the Cape over the past half decade plus, since the crisis really started being felt over 2012, 2013. Governmental and private institutions and individuals in Falmouth and the Cape have made a number of efforts to educate the public and provide opportunities for training and conversations around best practices. On the Upper Cape, this includes work in 2016 by the Opioid Coalition of Falmouth, which promoted awareness of OUD and worked on plans to reduce the availability of illegal opiates. Falmouth Human Services also held a workshop event in 2018 to help participants acquire tools to recognize addiction, respond to an overdose, and discover resources for treatment, including Narcan training. In 2018, 2019, the select board held forums on sober houses, as well as on the siting of a possible overdose prevention site in Falmouth. Numerous other groups, county agencies, and governmental departments, some represented by panelists here today, are also at the forefront of responses. Lesser known, of course, by the general public are many of the meetings, working groups, and institutional and individual efforts that don't make it into the newspapers. This forum includes many of those individuals involved in these efforts. Back in 2016, Falmouth Police Department Chief Edward Dunn summed it up well, saying, "We have a lot of commitment from the community," and calling for innovative ideas by saying that's what this is all about, bringing the community together and coming up with some out-of-the-box ideas. This forum is another effort to take up the Chief's challenge. Before we hear from Dr. Goulão and Dr. Jody Rich discussing Portugal's experience reducing harm caused by opioid use disorder, I'd like to introduce COBRE's Center's Deputy Director, Tracy Green, an epidemiologist and the co-leader of the core group, the COBRE core group, of which the Migrant Communities Project initiative is a part. She's going to give us some brief remarks on the state of the state after some Massachusetts state data was recently released for some context.
Thank you.
Tracy.
Thanks, Miguel. It's wonderful to be here, and thank you for the invitation to tell you a little bit more about some of the recent data that have been released by the state. So just to put ourselves in an understanding of what happened last year, an awful lot did happen with the pandemic affecting overdose really nationally in ways we've never seen it before. We saw a 29% increase nationally in overdose deaths, but Massachusetts fared a little bit better in some respects. We had only a 5% increase in the rate of overdose from 28.7 per 100,000 to 30.2 per 100,000. For me, that's a couple too many thousand people still dying, and it's just what we are here all today to talk about. But that meant that we had 2,104 confirmed and estimated deaths in 2020 last year. So about 100 more than what we experienced the year prior. But more importantly, and this is really speaking to what Miguel has been focusing on in his remarks too, is an opportunity to really understand who it is. And we've seen an enormous change in Massachusetts with Black, non-Hispanic, and Hispanic residents dying at far greater rates. That increase from last year, though small, represents a 69% increase in Black, non-Hispanic, mostly males dying. So their rate now meets that of Hispanic males. So our state is suffering greatly still from overdose deaths prematurely, but they're also changing the face of the decedent. What hasn't changed is that fentanyl is very much part of the illicitly manufactured fentanyl drug is primarily involved. 92% of the overdoses involved a fentanyl, and about half and also involved cocaine. So we've seen in some communities decreases in overdose deaths, remarkably, Lowell, Lawrence, New Bedford, Lynn, but we've also seen increases in places like Brockton and Worcester unexpectedly. As we learn and think about how we can help our communities, this is a community-based solution and approach that is going to be best informed and in the long run, empower our communities and our people to be healthy and safe. So just some thoughts, and really look forward to the rest of the afternoon's conversation.
Great, thank you so much, Tracy. And we'll be hearing from you later on in panel, in our fourth panel today on policy perspectives. So I'd like to just introduce the first panel now for you, a conversation between Dr. Jody Rich and Dr. João Goulão. Dr. Rich is the director of the COBRE on opioids and overdose, is a professor of medicine and epidemiology at Brown University, and a practicing infectious disease and addiction specialist at Miriam Hospital and Rhode Island Department of Corrections. He's published over 200 peer-reviewed publications, is the director and co-founder of the Center for Prisoner Health and Human Rights, and co-founder of the Nationwide Centers for AIDS Research Collaboration on HIV and Corrections Initiative. Dr. Rich has advocated for public health policy changes to improve the health of people with addiction, including improving legal access to sterile syringes and increasing drug treatment for incarcerated and formerly incarcerated populations, and has worked on the opioid overdose epidemic. He's testified in Congress multiple times and was appointed to Rhode Island Overdose Prevention and Intervention Task Force by Secretary, then Governor Gina Raimundo when it was started in 2015. Dr. João Goulão is Portugal's national drug coordinator since 2005 and has worked to coordinate the European Union response and is the general director of CICAD, the drug policy agency of Portugal's Ministry of Health. Dr. Goulão helped to develop and was a leader implementing Portugal's globally renowned transformative successful drug intervention policies. The Portuguese model, as it is sometimes called, has been examined by researchers and policymakers internationally and in the US, and has been recently part of the Biden administration's conversation developing as it develops national drug policies. Dr. Goulão has spent some time in Rhode Island, Massachusetts as a distinguished visiting scholar at Brown University, hosted as a guest by the Cobra Center. I'll let Dr. Rich tell you more about him as their conversation begins, but thank you and welcome Dr. Rich and Dr. Goulão.
Miguel, thank you so much. And I would just like to, first of all, acknowledge Miguel's hard work and his great work, not only with the COBRI and the Migrant Project, but also in arranging this forum and really being there and was invaluable during Dr. Goulão's visit. But I'm delighted to do this for Falmouth because I have very strong feelings about Falmouth, having spent every summer of my most of my life in Falmouth. So I love Falmouth. So I kind of studied medicine and then infectious disease, and then came to Rhode Island at a time when there was an outbreak. There was a lot of HIV, and it was mostly related to injection drug use, and sort of backed from public health and infectious disease into addiction, and work in the corrections department 1 day a week for the last 27 years, and have a very sort of unique perspective on this epidemic, and have sort of seen the opioid crisis and overdose epidemic unfold in a front row seat. And my practice has really evolved to thinking about infectious diseases and HIV, to thinking much more about addiction and the opioid crisis. And it's on the one hand, the more I learn about it, the more I understand it, the more I realize how very, very, very complex this problem is. On the other hand, it's very simple. You can describe it in very simple terms. So I'm going to just spend a few minutes breaking it down as simple as I can and show you where Dr. Goulão fits in my thinking on that, and then we'll turn it over to him. So opioids are different than other addictive substances with two physiologic properties. The first is, if you take an opioid every day for days to weeks, you will develop tolerance. And tolerance means you need to take a higher dose to get the same effect. So you start taking it every day 1 week, the next week it doesn't work as well. You have to take a higher dose because you develop tolerance. Said another way, the more you take, the more you have to take in order for it to be effective. The second property, which will happen to anybody, is that if you stop it, once you've developed tolerance, you will go into withdrawal. Now, withdrawal has, and I would encourage you all to, if you know someone or meet somebody who has this disease, ask them what withdrawal is like. But they will tell you that this is the most god-awful, worst feeling imaginable. You literally feel like you're going to die. Imagine the worst flu you ever had. Your head is pounding, your body is aching, you're exhausted, and then imagine the worst stomach bug you ever had. You're nauseated, you're vomiting, you have diarrhea. Put those two together and multiply it by 1,000. It's awful. People will do almost anything to avoid it or get out of it. So that the tolerance and withdrawal is what makes this disease particularly challenging. Because once someone gets hooked and gets into it, it's very hard to get out. It's like a boa constrictor. Wraps around you, wraps around you, wraps around you, and every time you breathe out, it tightens. You try and breathe in, you can't, tightens. Takes hold of you, takes over your whole life. Now, the simple part of this is that we in the US perceive this as a crime, as criminal behavior. Similar to the way 100 years ago we thought of people with mental illness, with depression, with schizophrenia. We thought they were just, you know, they if they just kind of had their head right, they would be fine. Just pull yourself up by your boots, stop being depressed, stop acting crazy, stop seeing visions. And then, of course, we realized, no, this is actually a disease that people with mental illness, if you put them on the right medications and put them in the right environment, they improve, they get better. We can care for them. We haven't made that connection yet in the US about the disease of particularly opiate addiction and many addictions. So we are confused. How are we going to treat this? How are we going to address this problem? Is it a disease and should we treat it like a disease? Or is it a crime? Is these people just need to be punished and then they'll stop doing it? Unfortunately, we're in the crime mentality. That's what we've done for the last, for maybe 100 years. We have treated this as a criminal entity, not a disease that needs to be studied, understood, and treated. Now, as such, until recently, and still to a large degree, in most medical schools, we don't teach about opiate addiction. And in fact, by not teaching the doctors and other healthcare providers to understand this disease, we left ourselves vulnerable because we didn't understand the disease. When the pharmaceutical industry came along and said, oh, we want to make a lot more money. How can we make money? Well, if we convince the doctors that this disease is not going to happen if they prescribe a lot of opioids, then they'll prescribe. They did an early focus group with doctors and they said, hey, we have a great new opiate. It's called OxyContin. And if we, you know, how would you like to prescribe it? And they said, oh, we're not going to prescribe that. People will become addicts. And they said, what if we told you they wouldn't become addicts and you could just treat the pain of all your patients? The doctor said, oh yeah, then I would do it. So the entire focus of the pharmaceutical industry was to convince doctors that this was not an addictive substance. People are not going to become addicted just because they take opioids for pain. And it worked. They took that strategy to the bank. And the doctors were vulnerable because they didn't know any better. They didn't know how to recognize opioid disorder when it happened, opiate addiction. And it set off this huge epidemic. And, you know, there were racial differences in how doctors prescribed. They look at a person who's Black or Hispanic and they said, oh, no, you might be a drug addict. I'm not going to prescribe to you. They look at a person who's white. Oh, you're just like me, because most doctors are white. And they said, oh, well, you poor thing, you're having all this pain. Here, let me write a prescription. So initially, this epidemic was hitting whites more than Blacks and Hispanics. And as you heard from Tracy, that pendulum has shifted because the epidemic shifted from prescription pills to heroin, because heroin is cheaper and more available, and then shifted to fentanyl because fentanyl is cheaper to make and more available now in the US. And of course, because it's an addiction, it's spread out to the more vulnerable populations, and the more vulnerable populations are poor, Black, and Hispanic people. And that's where the epidemic is now. So coming all the way back, the fundamental problem here is that we think this is something we should we should punish people for, and that's going to solve our problem. And unfortunately, it's not going to solve our problem. We have 3 medications that are highly effective: methadone, buprenorphine, commonly known as Suboxone, and naltrexone, available as an injection known as Vivitrol, the least effective of the 3. But all 3 of these medicines work if people take them. So, in a sense, we have a very simple job here. We have to get people who have this disease diagnosed, and we have to get them onto these treatments and keep them on these treatments, and they will recover. But many people are stuck with this notion that, oh no, people should just do this without medications. They should just pull themselves up by their own bootstraps. So we've got a sort of anti-medication mentality, and we're still stuck with this punishment. Oh, maybe it's treatment, maybe. And a lot of people in minority communities said, oh, now that you have spent all this time arresting and punishing Black and Hispanic people and poor people, now that the white people have it, it's a disease, and and that's a legitimate gripe. But the problem is, we still haven't stopped punishing it. We still punish this. Now, Dr. Goulão in Portugal, a few decades ago, led the charge to say, hey, no. This is not a criminal problem. This is a medical problem. This is a disease. This should not be under the Minister of Justice as a criminal problem. The disease of addiction, particularly opiate addiction, but other addictions, should be, and drug use in general, should be under the Ministry of Health. This is a health issue. That was a fundamental decision. And now, 20 years later, it's not just the wonderful programs that he's set up and nurtured along all these years. And it's not just the way people are processed through the system. And it's not just that the incarceration rate has gone down. What he has done and his charge has led has changed the culture. The culture in Portugal is not to think of this as a disease, as a crime, as something to be ashamed about, embarrassed about. It is a disease that needs treatment. As simple as that. So I will turn it over to Dr. Goulão to tell us about his adventure and his journey through this addiction. And I will say, in January of 2020, on the verge of the COVID pandemic, we convinced Dr. Goulão to come to Rhode Island and parts of Massachusetts, but really focused on Rhode Island for a number of reasons. Because I think fundamentally, the change we need to make here is the exact same change he did, that we need to treat this as a disease and stop treating it as a crime. When I started going into the prison every week in Rhode Island, prison and jail combined, I saw a lot of patients with HIV and with other diseases, and then I would see them on the outside after they're released. And it didn't take me very long to figure out that if somebody came in and had their addiction and their mental illness addressed when they came out, I would see them in clinic on the outside. And if they didn't have if their addiction or their mental health was not under control, then they would go back at intake. So the correlation, these were not criminal people. They were people with a disease. If the disease was taken care of, then they would function fine in society. So Dr. Goulão looks at us and thinks, what are they doing in the US? Don't they know punishment doesn't work for addiction? But Dr. Goulão's impact on the US and on all of Europe is phenomenal. and particularly on Portugal. So Dr. Goulão, I'll turn it over to you to tell us about your journey.
Thank you, Jody. Thank you for your kind introduction and also for your lesson about opioid disease, opioid addiction, because it's important for people to understand that it is really a severe health condition. I want to start by thanking the invitation to Miguel and all the colleagues. It's a pleasure to be with you. My trip to Rhode Island was the last one that I had the opportunity to do before the lockdown, the pandemic, and all that. So I am very happy to join you again. And to share also some ideas about how it happened. I will not go through the same kind of presentation that I did in Rhode Island, explaining a little bit the story of it, the conditions that led us to the decision of putting in place a system based on the health and social side of the phenomenon, instead of sitting it on the justice and prosecution side. But I think our recent experience during the pandemic is also very illustrative of the way that we feel it's the adequate way to deal with people. And this is a matter of people and respect for people, no matter the origin, the race, the social condition that the people may have. When this pandemic started and everybody went home, you only could see on the streets of Lisbon and other cities the most vulnerable, among whom the addicted, the addicts were included, but also homeless, also migrants with no papers, no regulation. And I was happy to be charged by my Minister of Health to take care of all those populations. I can assure you that it was I lived some difficult times in February, March, April last year, because we had to join all the people of the structures that could anyhow support those people. But thinking about people addicted to opioids, and you know, in our history, we had a huge number of opioid dependents. Most of them are now, were in the beginning of last year, were already included in programs, were covered, were in connection with treatment or at least harm reduction facilities, included in low threshold programs of methadone. But suddenly, but of course, we had still a population of people using heroin, street heroin. And suddenly, we had a shortage of heroin. There was no heroin available. The prices skyrocketed, and people could not afford to find heroin. And we feared that this was the moment when fentanyl would come in force into our country. Until now, this is not yet a problem with the dimension that we have been anticipating. We think it will come, but and we thought it would would be the moment for fentanyl to come into force into our market, but it didn't happen. One of the first things that we did, we have a response, a harm reduction response, that is drug checking. and we had it available until then only in recreational environments to detect new psychoactive substances, to better understand what was in the market. But in that moment, when we had that anticipation of the beginning of fentanyl use, massive fentanyl use, we have made available those facilities in the most vulnerable places, in the most in the neighborhoods of drug use, of heroin use, crack, with close to the most vulnerable populations. And we had a massive adhesion from them, taking samples to be analyzed, and because they all are already informed about what is happening in other places, in other countries, such as in North America. So they are educated, and this is one of the first steps to improve their health and their resilience to what can come to complicate their lives. So through education and through making this possibility of analyzing their drugs, they felt much more confident. But even then, they had huge difficulties in finding heroin in the market. So what we did was to open the doors of our low threshold programs of methadone. And in 2 weeks, 300 people joined the program in Lisbon. Just to speak only of the city of Lisbon, we had previously around 1,200 people on those low threshold programs. We have vans that circulate through town and stop at given hours in given places. People already know where to find the van and at what time. And we included suddenly 300 more people on that. In an uncomplicated way, I must say even the heroin users were surprised with the facility, with how easy it was to find a response for their difficulties. And as Jody very appropriately explained, this is severe suffering, this is severe pain, this is one of the most difficult to bear pains that people can imagine, is the withdrawal of opiates. So they got it the next day, they got it easily. And I think this illustrates the humane way that we address these problems. And the translation of this humane way is in the fact that really we decriminalize. This is, as I used to say, this is only one part of it. Is the way that everything in the system becomes coherent, because it makes no sense to even to try to develop those health and social responses if you keep criminalizing and having the possibility to put these people in jail on the first hand, but even to make a criminal record that is going to stigmatize this person for the rest of their lives, that turns impossible to find a job, that turns impossible to buy a house, to get a loan from the bank, everything. So, in fact, decriminalization, in my view, is an essential step to be given, even when in places as the United States, where you are discussing and you are legalizing some drugs that are still illicit elsewhere, but the meanwhile, decriminalize the use of every drug is, in my view, in fact, an essential step to develop a coherent and really to address the problems that you are facing in your society. Here, in fact, we had some difficulties in dealing with this situation. But I must say that it was also an opportunity to enhance the collaboration at several levels. Municipalities stepped in the front line to develop the responses to those vulnerable populations. And we could improve the collaboration of all the services, NGOs, and so on, that work in different areas. Some of them were working with homeless, others with migrants, but they hardly knew each other. So what we did was to put everybody working together, speaking, talking to another. By this means, this virtual means, we started very frequent meetings with the responsibles, and we could adequate and articulate all those responses to better fit to better respond to the real needs of those people. I must say that it was difficult anyhow. In the beginning, mostly we had no masks to distribute. Even professionals were very much in fear of getting the infection. We started working in mirror. Of the team was present in the centers or in the frontline responses. The others stayed at home, and after a week they changed. So we had some difficulties in absorbing all the treatment requests. Most of the services had less than half of their capacity. But we also improved the virtual forms of talking to people and orienting people to deal with their difficulties. And what I can say is we had a very, very low rate of COVID infections among drug users and all the vulnerable populations. The overdoses rate did not increase during this year and a half almost. We had almost the same number, around the same number. In 2019, we had 63 overdoses deaths in Portugal. In 2020, around 70. And until now, this year, we had 30. So it did not increase the number of fatalities as far as we know. Even if we know that the forensic figures are not completely accurate until now. But even then, it's the same order of dimension that we are dealing with. We took that opportunity also to launch and to gain the political support for new responses. One of them, we are talking mostly about opioids, but we had a problem with alcohol and with alcohol withdrawal. That, as you know, this is not as painful as opioid withdrawal, but it is perhaps most dangerous in terms of life the possibility of a casualty. So we gained the political support to create a kind of supervised consumption site for alcohol during these times, along with massive education for our colleagues, doctors, about how to deal with alcohol withdrawal, acute alcohol withdrawal. We launched guidelines and we made intensive work of information to better deal with it. And also took this opportunity during this period of pandemic. We opened also two safe injecting sites in Lisbon, and we are preparing the launch of one site in Porto, the second city of Portugal, that we hope will begin its activity after summer. So still this year it will be working. So it's I think I completely agree with Jody with his remarks about thinking about these issues as health and social and human problems rather than criminal, because in fact by enhancing the criminal prosecution we did not get any kind of improvement in the situation, and on the contrary, by working with this humane and pragmatic way, we are really dealing with those difficult times in a quite balanced way. So I'm completely at your disposal for whatever you want to ask, but I am really very happy to join you once again and to share our views. As I was and Miguel mentioned it, I had the opportunity to participate in a session organized by our embassy in Washington, D.C., and that allowed us to discuss the new Biden administration policy. And I think I would like to congratulate the United States for this new step, this new openness that I believe that can. And just a final word. As you can see by this, I'm now working as the chair. We are in our rotating presidency of the European Union. Portugal is having the presidency, and I am sharing the horizontal drugs group, that is the group within the European Union that discusses this kind of issues. And we had a meeting with the United States administration to discuss common ground, common steps that we can give. And we felt completely new openness of the United States authorities to discuss those issues, even harm reduction measures of harm reduction policies in a very completely new way, if by comparison with the previous administration. So I think you have also a window of opportunity to step forward in a more humane and balanced way. And thank you for having me completely available to reply to your questions, please.
Well, I think you've just been treated to a little bit of Dr. Goulão's magic, how he really just says things plain, simple, and clear. And one of the things he said is, well, I just wrote this down, respect for people. That's what treatment is. It's respect for people. And treating this as a criminal problem and punishing is the exact opposite. And you get the opposite results. You know, when you talk about decriminalizing drugs, we have this notion that, oh my goodness, we have a big drug problem and we better hold on tight to this one thing that we have that's keeping the flood out, that's holding the floodgates. We better not get rid of this criminal punishment because that's the only thing that's keeping it from getting worse. When in fact, that is what's making it worse. That's the whole problem. You can't have it both ways. You can't say, oh, you have a disease, come on over here and get treated. And then at the same time say, oh, but if we catch you, you're going to be punished and all the collateral consequences of that. That is that's really it in a nutshell. I think we're, and then you also heard Dr. Goulão talk about, well, here's this pandemic crisis, and what does he do? He keeps doing the same stuff. Well, we use that as an opportunity to help the homeless and get them treated, and we use that as an opportunity to work with the municipalities and develop collaborations and keep the population protected. And we opened up the low threshold, the methadone, and we took advantage of the slowdown in the economy and the lack of access to heroin to get more people onto methadone and to do it well. So it's just remarkable how he just is, and you can see him working at this for decades now has had, why it's had such an impact. I'm very interested, Dr. Goulão, in your work with the European Union. I'm wondering how that's going, and I like that the Americans seem to be listening to the message. I wonder if the rest of the members of the European Union are. Maybe you could talk to that and tell us a little about that.
Thank you, Jody. In fact, we of course, it's not easy to negotiate a common policy. It's not binding, but in any case, we just adopted a new strategy, 21-25. It was quite hard to negotiate, but it's a very advanced one. And our task as presidency, the Portuguese task as presidency, was to negotiate an action plan on top of that strategy that we hope to adopt next week in our final meeting as presidency. It has been hard, but it's a very advanced one. The first proposal that came was very much based on security, ensuring security and stop the migrants at the borders and avoid new opportunities to other people that do not belong to this space. On the contrary, the final version that was adopted in December under the German presidency is a very balanced and quite advanced strategy, stressing human rights, stressing harm reduction policies, stressing the need of availability of treatment for all those in need for that, quality treatment, evidence and science-based treatment to be available to everybody. So I think we are having also quite good energy flowing through Europe in this subject.
That's wonderful to hear. We have a question in the chat, and I would encourage everybody to put questions in the chat. So the question is, would you consider the prevalence of the AA model of total abstention and a reliance on a higher power as an obstacle to this model. And I guess the model is your model. Is maybe you could talk to the role of AA and higher power in Portugal. And is that
all the powers, higher or lower power, are welcome to help people who have this kind of problems. Who encourage people under the following treatment in the formal system to join the AAs to get their support. And it's not, and on the contrary, they AAs and NEAs are joining us, are seeking to interact with us and to ensure the follow-up of real people. So we completely consider that it fits completely in our model.
I would point out that SAMHSA recommends for people, and this is what I tell people when they have this disease, is that what you need is recovery. And recovery, as SAMHSA describes it, is 4 things, and it's a dynamic process. It's not you climb to the top of the mountain, you put the flag in and you're done. It's how you live your life moving forward. And these are 4 things you're working on. You're working on your health in a global, in a holistic sense. So your mental health, your physical health. You're working on your home, also in a holistic sense, a place you can feel safe and loved. You're working on your community, because we are social people and we need to interact with others. And you're working on your purpose. Now, 12-step and AA and many of these support groups have sponsors, have people that have been down this road before and can help guide you to not make the mistakes they've made. When you talk to sponsors and recovery coaches and people that work in this field, they are passionate about what they do. They're helping people, and they know what people have gone through, and that passion helps their own recovery. So in that sense, it's tapping into something, a purpose for these individuals. The problem I have is not with AA and the 12 steps. Some people are turned off by the religious overtones. Some people really enjoy that and it helps them. I think it's a mixed bag, but it's pretty much what's often used. What I don't like about it is some groups tend to say, well, if you're on a medication, then you're not really in recovery. And of course, that's not true. You notice I didn't say you have to be on medications to be in recovery. It's you're working on your home, your health, your community, and your purpose. And if the medications are helping you to do that, then that's still recovery. But there are some people in AA and NA and other movements that think that the medication somehow you're not pure. Now, I take care of a lot of patients with HIV, and they need to take their medications. If they don't take their medications, they're going to die. I take care of a lot of people with hypertension, with cardiac disease, with diabetes. They don't take their medicines, they're going to die. That doesn't mean they're not in recovery. That doesn't mean their disease isn't under control. They're using the medication to help them control, just like using meetings to help you control it would be helpful. So, and unfortunately, many people, even if they're on the medications and it's helping them, they come to a meeting and they're told you can't talk about those medications that you're taking. So then here comes somebody newly addicted and in trouble, and they go, if somebody says, well, you have to go to a meeting, they come to a meeting and nobody says, actually, if you get on these medications, your risk of overdose is going to drop by at least 50%. It's going to facilitate you getting into recovery. It's going to save your life. And so nobody's talking about it at the meeting because they're not allowed to, because that it's discouraged. And then they walk out the door and overdose and die. So I think that's the shame about it. But I completely agree with Dr. Goulão. We want all the power, and we want to provide support to people. Okay, let's see if there's any other questions. Okay, Dr. Goulão, when do you foresee the use of peer recovery coaches being implemented in Portugal and other countries in Europe? Recovery coaching is a harm reduction pathway.
Well, peer recovery. I think this is one of the lessons of this pandemic, is the involvement and the recognition of peers as effective and very, very useful and effective partners in this work. And once again, all the power that we can will be taken on board. The legal recognition of peers as at the same level of professionals is quite more problematic at the European level. At national levels, in some countries, is already recognized and has been put as legislation has been put forward to recognize and to consider the salary recognition of those of these partners. So I think we are in a good moment, and once again, this moment of pandemic opened some doors to this recognition.
Well, we have two more questions, but I'm afraid we're out of time. Perhaps, Dr. Goulão, you could type in the response to those two questions in the Q&A.
Okay, do you have an outreach program?
Yes, an outreach program. And the second one is, did you run into resistance for this approach from anyone in Europol and or DEA liaisons?
Well, outreach work is one of the bases of our harm reduction policies. Our first concern 25 years ago, our first difficulty was to provide treatment, to offer treatment, and as you know, we have a universal healthcare system for free for all the population. But the first step was to ensure the capacity to treat all the people who seek for treatment. Once we got it, we went to the street. We launched the outreach work, seeking for those who did not mobilize spontaneously to join the treatment facilities. So we have in place, and this is one of the bases of our work, street teams and some social responses such as shelters that ensure the most basic needs of those vulnerable people. So outreach is really one of the key parts of our policy. On the other hand, we did not have pressure from DEA, I would say, but we had from the United Nations bodies when we decided to decriminalize. They had put a lot of pressure. Effectively, there is no sanctions that they may apply. But in fact, in international negotiations, if the United Nations reaffirm that you are not under the spirit of the treaties, we are running out of it, that may fragilize you in the international context. But in fact, it lasted for a couple of years, because when we started to show our results, the UNODC, for instance, and the INCB started to say, oh, even if Portugal decided to decriminalize, they seem to have effectively good results. And there are some European countries that now are following that pathway that was opened by Portugal. That's the case of Norway, for instance, that is going to adopt a policy, a decriminalization policy, very, very similar to ours. I expect that this could be approved still this month of June. We had several visits from Norway. The Minister of Health and the Minister of Justice came here to my office. We had a long discussion. We had parliamentarians, professionals from the ground, the people from academia, and all together they discussed, they had built together, and they decided, okay, this is a way. So we are very happy and very proud of it. But, so this is not true that no one is following the same kind of steps. We are happy that yes, they are moving.
Great. Miguel, do you have time for the last question?
Yeah, sure. I think we have time for. We should keep it brief, but yes.
Okay. There are decades of clinical trials and thousands of years of indigenous experience demonstrating psychedelic plants' efficacy in treating traumas and assisting with addiction. And members of James Davis's team, who's asking the question, use their stories of using plants like ibogaine to overcome opioid addiction to convince 4 cities in Massachusetts to decriminalize all controlled substances and cultivation of psychedelic plants. He wants to know if psychedelics are on your radar. I would just point out that this is a chronic disease, opioid use disorder, and the notion that something could be cured is not the way we talk about it. It's a chronic disease. It's more like hypertension, diabetes, something that can be controlled. But I don't want to leave the impression that you can take some ibogaine or some other plant for a few days or weeks or months and then you'll be done with it. It takes years and many people need treatment for longer. But Dr. Goulão, are psychedelics on your radar?
Well, there are some trials going on. There are some attempts to introduce this kind of substances in the paraphernalia that may be used, but I would say it's not a central issue nowadays in our radar. We have other kind of priorities. There are some people on academia working on it, but this is not a priority for us, honestly.
And James did say overcome, not cure addiction. So I don't want to misrepresent his thoughts. But Dr. Goulão, thank you so much for spending the time. I know it's about 4 o'clock in the morning there now, and we really appreciate your spending the time with us, and look forward to more wonderful communication.
Jody, it was a real pleasure to meet you again, and Miguel and all of you. And thanks again, and congratulations for organizing this meeting. I think it's very, very timely, and I hope that it may help to move forward. So whenever you want, I will always be available to be, and I hope to have you here. Miguel, I know you are coming to Lisbon one of these days, and I hope that Jody can come also, as promised, more than 1 year ago when we met in Rhode Island. Thank you to you all. Thank you.
Thank you, Dr. Goulão. Thank you, Dr. Rich. Okay. So our next panel is going to be introduced by a community impact statement from Corey Green, who is the treasurer of the Cape Verdean Club of Falmouth, and who's been greatly involved with a number of initiatives here in Falmouth with the Cape Verdean and Portuguese-speaking communities in Falmouth. One of the co-sponsors of this event is, of course, the Cape Verdean Club of Falmouth. And Corey Green works at Beth Israel Deaconess Hospital, and she has her community impact presentation right now. Corey, hi, welcome.
Hi there. Hi, everybody. So my name is Corey Green. Hi, my Aunt Barbara Miguel. Thank you, and thank you to the doctors that were speaking. I just want to briefly say that I've had probably more experience than most with my own battle with addiction, with loss of loved ones, and with the impact now that is still going on some 30 years later that I've now experiencing with my son, who is an addict. So I agree with the speakers that talked about addiction and not to be criminalized, but a lot of that is what our country has done, and not to reflect on addiction as a disease. I've been fortunate enough because over 30 years ago, I myself was an addict. And I not only was I addicted at 21 years old, but I also lost my sister, who when we wanted recovery or as we were trying to get into treatment, it wasn't as easy as it is, or maybe as Portugal has done to reach out. But we thought at that time we could kind of do our own detox. And when you talk about the worst pains, and when you talk about the sickness of withdrawals of opiates, it's as the Dr. Rich had said, one of the worst things that addicts have to deal with, and they fear that. We fear that as addicts to be sick with withdrawals. It's sometimes easier to stay sick in your addiction. And I stayed sick for a while, but as I said, I lost my sister, and I spent probably about another 18 years watching my brother, who was an addict as well, in and out of prison, in and out of jail, in and out of treatments, in and out of hospitals, in and out of a lot. And it was 18 years, and I was clean, and I watched my brother live the cycle of addiction. And I didn't think that he was going to make it. I didn't think my brother was going to make it out of this disease, because unfortunately, most of us don't make it out of this disease. Most of us lose our lives. And I'm fortunate to say that my brother today has been clean and sober for over 12 years, and he did make it. He's a miracle. And the miracles that impact the addict, we take them because we've lost so many. And I can't tell you the countless friends and the countless family members that have been affected in the loss of this drug, particularly opiates now with the fentanyl. And then to say that at a young age, I spoke to my son, at 12, 13 years of age, and I spoke to him about addiction, and I spoke to him about alcoholism and choosing friends, because I believe some of that genealogy for addicts could have been passed on to my son. His dad was an addict. He was incarcerated for dealing drugs, and we had a long talk, and I wanted my son to not be a statistic. I didn't want him to be a statistic of the disease, and I didn't want him to be a statistic of society as a young Black man. And he was very gifted, talented athlete. He was very academically smart. He went away and did a prep school year and everything that you could imagine and want the best of. And yet and still he had an injury. And as Dr. Rich spoke, I worked in healthcare, and I worked in healthcare for over 25 years. So, as Dr. Rich spoke about that, he got prescribed medication for a torn ACL. He tore his ACL playing football, and then he tore the ACL again. And every day I monitored the medication. And then the third injury he had playing basketball in the neighborhood and broke his elbow. And that's where the addiction started with the opioids. And he's also from the addiction to the Percocets and then the oxys and everything else that came along. It was heroin. And he's been addicted in the struggle for the last maybe five or so years. So now as a mother of somebody that has gone through my own struggle with addiction, and through the grace of God and treatment and that I was able to obtain, to now have that on my son, as a mother, you worry, you worry about the calls. You worry if, someone's gonna be knocking on your door. And those are the things as I pray, and I've done a lot of work to get my son into treatment. And I've had a lot of help from people on this panel, Lenny Cardoza, he knows very well. He's been very helpful to me. And anytime I call him, and I feel like anytime I call him, I'm like, Lenny, it's time again. And it's not just once that he's turned his back and said, oh, well, he's tried it. Corey, he's never, ever said, well, every time you got to try again. As long as they have an opportunity to try, we have to support it. My disappointment with, the system is that there's really not enough treatment on demand. If somebody is sick and suffering and they want treatment, you got to wait 2-3 days. You got to make 5, 6, 10, 15, 25, 35 phone calls a day to try to get to bed, depending on, sometimes it depends on your health insurance. I'm not gonna sugarcoat it. I've had, when my son was covered by my health insurance plan and we had, great health insurance, he got into treatment. It was really not an issue. If things change in your life and now you maybe not have, then you might have to be on that list where you're in a bed for those that don't have insurance, or you're in a bed because, hey, I'm trying to get in, but I may not have coverage, and it's not treatment on demand. And I feel like that area really needs to be addressed, because when an addict is sick, they need to go today, because tomorrow they might not be here. So from a perspective of an addict, and from a perspective now as the mother of an addict, I can tell you that the experience that I have, I wouldn't want anybody to have to, live through and with, but it is what my life has been. I've dealt with the penal system, from court systems to the prisons to the jails. I watched my brother, like I said, in and out of institutions. And the last time that my brother went up in front of a judge, she said, you're going to go to treatment or you're going to go to jail, Mr. Burgo. Make your choice. And he made the choice, and he went into treatment, and it worked for him that time. And through the grace of God, my brother is alive, he's clean, and he's doing well. And I feel blessed, to have this opportunity to talk to you, to share my experience, to share my hope, to see that things, can change with what we have to put out there as a community, and on a national level, to make the changes that need to happen to make things right.
That's great. Thank you so much, Corey. Really, really appreciate your sharing that with us. And it's a great start for our next panel. So thank you very much. I really appreciate it. Thank you. We'll leave the rest of the of this panel to our law enforcement officers who are here with us today, and also the training coach Lenny Cardoza that Corey mentioned. I'd like to first actually introduce the Chief Dunn, who's the chief of the Falmouth Police Department. He came up through Falmouth Police Department and has been really at the forefront of some of these responses, calling himself for outside of the box ideas, as I mentioned in the introduction, that our forum attempted to take up his challenge that he put down in 2016. And also Lieutenant Michael Cimino, who I would say is probably one of my oldest friends that I have. We grew up across the street from one another, and I spent a lot of times in his house with him and his brothers and sisters and family. Mike and I, we were talking about, it was actually our mutual aunt also passed away. And we were talking about, just about some of the things that we were doing at the time. And he mentioned some of his work and some of his challenges, trying to work on opioids in Falmouth, and try and change some of the approaches. And when you started talking about this, that this kind of gave birth to the idea of this forum here in Falmouth. So I also wanted to mention that about Mike. And then the discussant will be Brandon Del Pozo, who is a former police chief of Burlington, Vermont, and currently a postdoctoral research fellow at the Miriam Hospital and a thought leader, a national thought leader on policing and opioids. So welcome, Chief Dunn, Lieutenant Simino, and Chief Del Pozo. I'd like to open this up to you, and I'm sorry, also Lenny Cardoza as well, who I briefly mentioned, is he works at Gosnold and is a really important partner of Lieutenant Simonos in his efforts to try and help people to get into treatment. So welcome, Lenny, Chief Dunn, Brandon, and Lieutenant Simino.
Hey, thanks. It's great to be here. Would you like to start, Chief Dunn?
Sure, I can shout out. We're fortunate that we've been able to partner with a lot of good partners here. And as you mentioned, Miguel, we've had some different summits and things like this. This pretty much all started back around 2012 when I became chief. Prior to that, you had overdoses in town and things like that, but they were few and far between. But when around 2012 was when it really started to surface, and I started getting phone calls from the community saying that we were letting people die here, and that was even pre Narcan uses, because police departments were not allowed to use Narcan. So my team, Michael and we here in the police department really started having some serious discussions. So what could we do better? Because my answer to the people that were calling me is it wasn't our problem at this point in time. We can't fix something that was broken long before it got to an overdose. And it was a community problem. And that's when we started reaching out to the community. We reached out to the hospital, we reached out to Gosnold, we reached out to the clergy, and reached out to other community members to see what we could do to move forward. And we were very fortunate to have a good relationship with Gosnold here and have a team and be able to partner with someone like Lenny, who works well with Michael and my other officers here in the police department. And we held a opioid summit where we invited the community. We invited doctors, and we had breakout groups, and we had the school involved, and we had all our partners at the table, and that's what we figured we could do to move forward. That being said, the problem didn't get any better, even as we had rolled up our sleeves and started to work. The numbers actually got worse. So we didn't give up, but we also at that particular time, it was at a time that we were finally able to get Narcan in one of our toolkits here. So we weren't having people dying per se. We were able to save lives. The legislators finally came around and allowed law enforcement to use Narcan. In fact, I'm proud to say that the Falmouth Police Department were one of the first departments to use Narcan here on Cape Cod. And then eventually just spread across. So now that all our offices, all the departments on the Cape use Narcan as a tool to help save lives. But the real workers here in this are Michael and Lenny, who do the follow-ups on these individuals that we deal with once they've overdosed and some of the things like that. So I really want them to have the opportunity to speak a little bit about what the program does and some of the success stories. And so, Lenny or Michael?
Thanks, Chief. Hi, everyone. Mike Simino, Lieutenant, Falmouth Police Department. I've been on about 23 years, so I've, like in the beginning, like Chief said, there was the occasional overdose, but and then when our town started getting flooded with the pills from down south, we really got hit hard. And the oxycodone and the oxycontins, selling for $1 a milligram a pill, and they were flying out of the drug dealers' hands. We couldn't control it. around 2014 when the hills dried up. That's when the heroin took over and really started to decimate the town. Right at the beginning of 2015, we began our outreach efforts with Gosnold and haven't stopped. It went from going out once a month to every week. It didn't take long to switch over to every week, and it started with myself and Lenny, and then our team grew to 3 additional officers because of due to the demand. And we've been going ever since. In the beginning, it was a little shock for people to have a knock on the door from us. They saw a police officer initially, and they didn't know whether to run or what to do. But we right off the bat, we were able to communicate with people, kind of stop them in their tracks, let them know why we were there, and it's been a huge success. A lot of these people, that were in trouble, they have never ever been, a lending hand was never given to them. They were never offered help, and that's what we heard out of a lot of people's mouths, that no one has ever offered to help. And to get that knock on the door and to get that help, in the beginning, I love to say that we had people jumping in the unmarked cruiser. We deliver them straight to Gosnold. It has slowed down a little bit, the interest in doing that, but I got to say we did. There was at least a few that jumped right in the car that day, back to trash bag, and went to rehab with us, which was pretty neat to do and be part of that. But like I said, the addiction issue, continues in Falmouth. We're seeing a lot more of the manufactured press pills, getting them off of people. Still the heroin, still plenty of fentanyl, and it's a battle, and we battle it on that front also. It's a multi-pronged approach with the drug interdiction suppression and the outreach work we do. So we do it from a lot of different angles. But I think we are making an impact, and people now, I think if people overdose in Falmouth, they know they're going to get a knock on the door, and we are there. Unfortunately, we do have a lot of transient people in town due to the services we offer. They're coming in from out of town. We don't locate everyone, but we make it our best effort to locate everyone. And real quick, I'd like to pass it over to Lenny Cardoza from Gosnold, who has 13 plus years of sobriety. And he's a champion in the recovery field. He's a superstar, which he gets mad when I call him that kind of stuff. But it's too bad because he really, really cares and works alongside us, does the same thing we do, and does more. So Lenny, if you want to say a few words.
Yeah, I'll say a couple of words. How you doing? I'm Lenny Cardoza. I'm a recovery coach for Gosnold. So I started working with the PDs. I think we started in 2015. And this was all new to me. I didn't know if this program was, how the success was going to be, and what it entailed. But I love doing what I'm doing. In the beginning, it was tough because you have to break down the barriers. Once we knock on doors and do a visit from somebody who has a non-fatal opioid overdose and offer them treatment. In the beginning, they didn't trust nobody. You know what I mean? I always say, because I used for 13 years, that I wish I had this opportunity when I was using, that somebody knocked on the door to offer me treatment. Unfortunately, if somebody was knocking on the door for me, it was going to be, it was a drug search. It was going to be, I was going to jail. So, I wasn't opening the door. But once this program started up and the people in the community started to know what we were doing, we were being met with a lot of people who opened the door. They were curious why we were there. A lot of them would recognize me, and they were like, well, what are you here for? What's going on? And we would tell them, we're just here to offer you some information, some resources, something to help you out so you don't have to continue to use. And a lot of them were, reluctant in the beginning, and they would take the information and they just weren't sure what law enforcement was doing and why they were doing it. And then we'd get the phone calls, or they would they'd invite us in, and they would take treatment. The biggest barrier in the beginning, like I said, it's insurance. Insurance is a big problem. Getting the people into treatment right away. If you don't have the right insurance, you may have to wait a week or two. Where this program was created, we were able to get people in within a 24-hour period, which helped offset with them calling. So that took a lot of interest. Once we've been doing this, for the last 6 years, me and Mike, it became a word of mouth. It became of somebody overdosed, they were going to get a visit. But they were no longer scared. They were no longer hiding and running and peeking out their windows. They were actually opening the doors. And the good thing was, once we opened the door, the program started to expand, because once we would go to overdose visit for one person, we started to find out there was multiple people in that house who needed treatment. You know what I mean? And, or they would call and they say, well, I have a friend now who needs treatment. So now we're helping a lot more people. You know, then it worked over to, like, you know, people in the community who are alcoholics, you know, and they heard about the program. So it was no longer just for opiates, it was for anybody. And they could reach out to the Falmouth PD and they would be linked to me and we could make a referral. And to this day, like I said, I have people call me just from word of mouth working with the Falmouth PD. You know, if they just don't know, they hear about this program and, like, they'll reach out to me and, like, you know, I got your number from Officer Simino. I got your number from this officer. Like, can you help me? And the good thing about peer-to-peer is, like, you know, they trust me. You know what I mean? And that goes a big way with somebody who's in active addiction, to trust somebody, because, you know, they don't trust too many people. And when they see somebody who's been through what they've been through, you know, they can relate to that. You know, so I think this program has helped many people in the community. You know, when I first started, we worked with, I believe, 3 communities on the Cape, and now we're pretty much working with all 15 communities. And, you know, if you had asked me what I thought I'd be doing, you know, 13 years later in my recovery, you know, I wouldn't think I'd be partnering up with law enforcement to offer treatment. But, like, this is what I do, and I try to make a difference. You know, today I work with 29 police departments. And that's a big difference for me, because if you had known me when I was in active addiction, I was actually, I've been arrested by the Falmouth PD 4 or 5 times for selling drugs, doing drugs, and everything else under the sun. And today, you know, I'm the guy that they call for help in the community, you know, and I believe, you know, without them, I wouldn't be where I'm at today. And I just love giving back. And I believe this program can work, you know, if with the right people. Okay, that's about it for me. If you guys have any questions, just let us know. Thanks.
Hey, so thank you. And for folks joining in, this is, I'm Brandon Del Pozo. I'm a postdoctoral researcher at Brown under the mentorship of Tracy Green and Dr. Jody Rich. I also served for 23 years as a police officer, 4 in the Burlington, Vermont Police Department as the chief, and 19 in the New York City Police Department. So I'd like to thank Dr. Muniz for asking me to be a discussant. I guess skip over, it's worth saying I did lead the response to the opioid crisis in Burlington for 4 years, and our approach was not policing. Policing had to be a part of an approach, but the approach was centered on public health, and it really concentrated on getting out these effective medications. I know that there's a lot more to treatment and recovery than just the medication in the long haul, but as a cop with a focus on saving lives right then and there, stopping the overdose crisis, it's pretty unambiguous that the medications are very, very effective. So we centered on getting them out in the syringe service program, in the emergency department. I hired an epidemiologist and a social worker to do a lot of the work that Lenny talked about, for example, or Lieutenant Simino or Chief Dunn. But today I just wanted to just facilitate a discussion, because I think there's so many interesting things we could dive into. So my first question is for Lieutenant Simino, which is, you know, when I did a home visit program, people were literally jumping out the back window when they saw the police coming. And in fact, there was a pattern burglar we were looking for. We didn't know he was going to be at this location, but when we knocked on the door, he comes out the back window. Oh, there's the guy we were looking for the last month. Other than that, there was not a lot of trust at first. So I guess I'll say, question-wise, what would you say to the skeptics out there in public health and to the skeptics out there in the harm reduction community that say the police shouldn't be doing this, to get them to understand your program? And then what would you say to somebody like Lenny Cardozo many years ago, right? Who says, police, I'm going out the back window too. What would you say to them to get them to listen? Like, what kind of advice would you give to each side about what you do?
Well, in the beginning, it was very out of the norm for the police to be. I never in a million years would have thought I'd be doing outreach work as a police officer. I tell you that right now. And in the beginning, there was zero trust. I mean, there were literally people like ready to bolt, and I just had to catch them. And I've always had a way with people. I enjoy talking to people. I enjoy talking to, people we deal with sometimes are, you know, they're committing crimes, they're using drugs, but I enjoy speaking with them. They are people too, and people, you know, some people forget that they have lives, they have a story. I like to hear the story. So, and I think people kind of learned that about me over the years and knew they could talk to me and they could trust me. So that helped in the beginning, because like I said, it it was a pretty daunting task to be able to get people to stand still or not to run on you, and just to listen for a minute. So for the people, for the naysayers or people don't think that police officers have a seat at this table, I think they're totally wrong. I think we have a strong, we deal with this community, it's a day in and day out. We're there in their lives, and it does. And I think the right officer has to be doing this work. It's not for every officer. And believe there was the naysayers in our own organization who thought, oh, this isn't going to work. But now those same people are, saying, hey, oh, can you? I dealt with this person. Can you give them a call? I don't. And they're kind of buying into it also. So I really think that, like I said, it has to be the right person, and you're going to see success. But what was the second half of the question?
I was asking what you'd say to the people in the community who don't want to see the police knocking on their door, and then also what you'd say to the cops who think this isn't police work. I think you did a great job with the first part. Maybe what would you say to the, I'll just, for lack of a better term, for young Lenny Cardoza, what would you say to young Lenny, to get him to open the door?
Just give me a chance. Give me a minute of your time. I'm very simple. I'm very open. We understood you had an incident the other day. Can you hear us out for a second? And the more down to earth you are, and the more regularly, people have responded. We've never been turned away since the first visit. We've never been turned away. More often than not, we get offered it. We get invited in. We sit on people's couches. They offer us coffee, a cold drink. But in 6 years, we've never been turned away. So I think it's the people that are doing it. Lenny knows a lot of people in town. I grew up here, born and raised here. I know a lot of people. The way I've done my job for the past 20 plus years, people know that. I think they respect me, and I'm honored they do. But that's the way I was raised, and I believe I haven't changed a bit. I'm the same person I was when I took the oath in 1998. I'm the same guy. I'm a down-to-earth guy, and I think people recognize that and trust that.
Yeah, no, it's good that you say that. So I came on in 97, so we're from that same generation. A lot has changed since then. I do have another question for you, but I wanted to ask Chief Don one or two questions. Just keep it, in rotation. It looks like the overdose crisis is changing a bit in the Northeast. There's more stimulants showing up. I think the cops are getting to a point where they understand overdose with opioids. They understand Narcan. Stimulants seem to be, in the places where they're rearing their head, a game changer. I was wondering what your sort of police prognosis is for that. If Falmouth is seeing that, if you're giving Falmouth, sorry, gotta get that. If you're seeing the that change, and if you're trying to stay ahead of it, what you think you're going to be doing to respond to more methamphetamine use, maybe increases in cocaine overdose.
Yeah, cocaine started to make its way back again. I think what was happening too is we learned from some of the classes that I was in. We started hearing, because of the number of people dying from the heroin and the fentanyl, the dealers were switching to the stimulants and things like that. However, they were still lacing it with fentanyl, so it didn't really help. We've seen a little bit of an uptick, but not as much probably as other communities throughout the Commonwealth of Massachusetts. We're still pretty much dealing with fentanyl and heroin here in Falmouth. Where is it going to go? I mean, we're constantly we're trying to stay ahead of it, trying to figure out, as Mike and Lenny is a superstar in this, by the way, even though he doesn't give himself enough credit. The program is successful because of Lenny. It was getting all the other departments on the Cape involved in it so that we're all going in the same direction. We wanted to make sure everybody that was involved in this was at the table so that we're all doing some great things. So where is it going to go in the future? I don't know. We really, we're trying some different things. We're going to be trying to roll out a program called the Hub very shortly, which is good because a lot of this is we're doing reactive, like Michael said. We're going out once a week now, but those are pretty much follow-ups. What we want to do here is try to be proactive on this, have more people in the police department, more officers, the right officers, as Michael says. You got to have the right person, and maybe have a counselor full-time here at the police department that we can go out and proactively seek out these people before they get in trouble.
Yeah, and so I do have, it's good to know that stimulants aren't like a vice grip yet, but maybe they're coming, and to give some thought to how to react, because, you know, Narcan is not an antidote to a stimulant overdose, right. And there are no approved medications. So Lenny, you work with Lieutenant Simino, who obviously is a people person, good with connecting. He alluded to the fact that not every cop feels the same way. Not every cop has that same set of skills. You know, what would you want if you could get? You said you work for all these police agencies. If you could get all of those officers from all those agencies in a room all at once, that would be a scheduling nightmare for the chiefs. But let's say you could do that somehow. What would you want them to know from your perspective as a person who's working with police but was on the other side of the fence? What knowledge would you want to convey to every police officer you could get your hands on to let them know your message?
Well, like I said, each department I have, they're pretty much handpicked. Each person I work with, it's got to be empathy, compassion. It's got to be the right officer, depending what they're doing in the department. Like I said, you know, Mike's like, he's awesome. You know what I mean? So I would tell that officer, like, you never know, like, who you help and what you do, the impact it can have for that person. You know, like some officers, you know, they're stigmatized. They don't want to help the addict, or, you know, this person's not going to get it. You know, I was there for 13 years in active addiction. You know, I've been arrested probably by Mike or Chief Dunn for selling drugs in the community. So like those people who helped me out never knew like it's going to be the role's going to change. You know, unfortunately, I came through my addiction 13 years later, and the officers that maybe thought that, you know, I was a pain in the butt to the department, being arrested, coming into the Falmouth department over and over and over, being arrested and like a nuisance to the community. You know, that sooner or later, you know, through you know, with recovery and mental health awareness and stuff that I was able to do, I was able to come around and help them. And today, like, I help a lot of police officers who reach out to me. They have loved ones. And what's big about the program is, you know, we do go out, but we go out a plainclothes officer and an unmarked cruiser. So therefore, that helps us out. So when we pull up to the house, it's not a gun cruiser, and the officer usually doesn't have his uniform on. So when we're knocking on the door, they're opening the door, not knowing who they were talking to. But we do identify ourselves, and we let them know right from the get-go, like, you're not in any trouble. And then we explain to them what we're doing. And a lot of them are like, wow, this is awesome that you're offering treatment. And it's important that the program stays consistent. Like, we don't go looking for information about where you got the drug from, who's selling the drugs. We're not looking for information. We keep the program separate, and they have to trust us. You know what I mean? And so I would tell those departments, like, you have to handpick a specific officer who's trying to think of the word, who really wants to do this work, who really wants to do the outreach. You just can't stick any officer and expect them to do it, you know, because some of them don't care about the person and they just don't understand. You know what I mean? So it's got to be a hand-picked person. Each department I work with, I have that special individual.
Right. I guess that, no, please go ahead.
Yeah, go ahead. Yeah, go ahead. You can finish.
No, the difficulty seems to be the officers. That one of the things I found as a chief is I had officers who were totally on board, understood the value, and then others who were against it. And some of the folks in the community almost saw it like a little bit of a Dr. Jekyll and Mr. Hyde. You know, I see Lieutenant Simino knocking on my door, and I know I have an ally, but then I see another officer and I know I got to go out the back window. And that's tough sometimes, right?
Well, like I said, it's finding the right officer. If you got somebody who's doing crime, street crime, and, you know, he's doing all the bust, sometimes that's not the guy you want knocking on the door because, you know, maybe he had a problem with that altercation or somebody that they had to arrest. So like,
right. But what would you want that street crime cop to know? What kind of wisdom would you want to impart on the street crime cop that hasn't fully bought in yet? What would you, if you had a minute to talk to them, what would you say? Like,
you got to be, well, the problem is it's hard to keep it separate. You know what I mean? Because they have to do their job. They have to arrest people. It's hard to keep it separate and understand unless you really have a loved one and you come with that compassion and that empathy. But I mean, yeah, I would say, like, listen, you know, people do change, and like, you know, that person could be struggling with substance abuse and mental health. Like, we don't know what's going on with that person. But I mean, yeah, it's really tough because they have a job to do, and I just don't know if they can understand the other side of it. You know what I mean?
Brandon, I don't know if, I mean, the chief will attest to this. I don't know if I have split personalities, but
no, not you. I'm no.
No. Listen, I've kicked in doors and I've knocked on doors. I do both.
Right.
I've done both. I was on the drug task force for years,
Right.
and did that type of work, and I'm doing this type of work now. So there is hope for people who think that the big bravado tough guy. It happens, but I mean, like I said, I've done both, and I've been fortunate to be successful in both. But we are out there. There are guys
Yeah,
out
no,
there.
I'm just saying that's one of the challenges when you talk to people who are firmly in the harm reduction camp that don't want the police involved at all. They talk about this this tension. So that leads. I saw that Lieutenant Gagarian has a question. I'll ask that in a moment. I see it, but since I have you right here on the screen, Lieutenant Semino, what do you make of, or what's the sentiment towards Good Samaritan laws? So it's two questions related. One is Good Samaritan laws have been around for a while in Massachusetts. They have a long history in Vermont. What's the attitude on the street as far as cops go towards them? Some say it makes their job more difficult. Others recognize that they're important for saving lives. And then also a question is, what do you do with warrants when somebody has an active warrant and you're contemplating outreach? If you could talk about.
Well, I mean,
you see how these are related questions.
I'm going to be honest. I mean, the Good Samaritan law in the beginning, from a lot of officers, was like, "Oh, come on, there's a crime here. We need to act." That didn't take too long, to go by the wayside, just because of the magnitude of the problem we were facing. When we had to overlook small amounts of drugs on the scene, things like that. Now they're just collected and destroyed. Like I said, it didn't last very long. The attitude toward it at first was like, "Oh, we have drugs here. We have to act." And the new law says we can't. I mean, if they called asking for help, we respond. There's a small amount of drugs on scene, we will collect them and destroy them. If there's a large amount of drugs on scene, then that goes by the wayside, and we'll take some action.
So you'd actually use your discretion with some of the drugs on the scene.
Correct. If there's a small amount of drugs left on scene at the scene of an overdose, and they've called for help,
right?
Then they get collected and destroyed.
No, that's great. I think that one of the things people don't fully realize is how much discretion, in addition, above and beyond the Good Samaritan laws, any cop, if you were a cop from 98 onward, I just say over 23 years, like I remind people, there's a lot of drugs that we could have made arrests for that we ended up in the older, I'll just say it, like putting in the sewer, like instead of not that you do that, but I remember in the 90s, like I'd see my bosses saying, there's no interest in making this arrest. These are just kids, get him out of here and don't ask any questions. That's not necessarily the right thing to do. I know if there's a chief on the Zoom, they're puckering, but it goes to show that cops, it's more about problem solving than it is about just enforcing the law, which sort of brings us to a question by Lieutenant Gagarian, or at least an observation. And I was wondering if Chief Dunn could ring in on this. He says decoupling the use of intoxicating substances from the criminal justice system is of the utmost importance. Self-directed behavior should never have become a crime of any type. How do you plan on helping evolving policing to open minds faster, further towards, I'm paraphrasing here, towards 21st century policing so that we can become guardians? Now, I hooked up with Lieutenant Gagarian. I met him at a PARI meeting 2 years ago. He says, if I can ever make it out to Winthrop, I'm getting a lobster roll. So a lot of incentive right there. Falmouth, if you're listening, he just threw down a gauntlet. But Chief, what do you say about the movement towards decriminalization? For example, Vermont just passed a law that I'm so proud of that decriminalizes unprescribed buprenorphine. If you have some Suboxone in your pocket and you don't have a prescription for it, they're not going to collar you. I started making that a policy a few years ago. That's also being considered in Rhode Island, and that's just Suboxone. There's moves like what's going on in Oregon, which is decriminalization of the full range of controlled substances. I don't expect you to take a full-blown policy position on all of this, but like just to share some thoughts as a police leader on trends in decriminalization and where you think the right answer should land.
That is something that has been discussed as we're moving along by many chiefs here. I mean, because we just recently, as you know, marijuana was decriminalized and everything, and it was always considered a gateway drug, and the world was going to come to an end once that was decriminalized. It really hasn't, but I understand there are states that have done it. As far as how it's going to work, I don't know. And I think some of what you said there, and he talks about being the guardian. our officers do use discretion on some of these cases when we go to these calls. I mean, if they go to an overdose and there's, you know, personal use there, just like Michael says, it gets collected and destroyed. If they end up in an overdose and there's a house full of heroin there, it's a little bit different. You know, you got to kind of weigh the situation. What do you have here? You have someone that's dealing and probably selling it. So that you're going to take a different avenue there. So I think we're already using the Guardian model here as we deal with each case individually. But as far as the overall decriminalization, depends on what's going to be decriminalized.
Yeah, do you have any thoughts or any insights on this movement to decriminalize personal possession of Suboxone? The argument goes that it's a treatment medication. It has a ceiling effect. It doesn't give you anywhere near the high that heroin or fentanyl gives you. And a lot of people use it for two reasons. One, they'll either tell you they can't get treatment, or they'll say this other thing, which is very interesting, which is, I don't want treatment right now, but I'm scared of overdosing and I just need to make it through the next few days. I get it. I'm not like in treatment, but if I can get a few strips of Suboxone, I feel like I can make it through a tough part in my life and maybe survive another week until I can figure things out. I was very sympathetic to that as a chief. I'm not saying you could see I'm wearing my heart on my sleeve. You might not have a fully developed opinion, but do you have any thoughts on that? It's the law in Vermont and it's being considered in Rhode Island.
Okay. No, I really haven't, you know, and I'm open to a conversation with it. Absolutely. Kind of what we've done here too is for those individuals, because what I found on early on, I mean, our numbers skyrocketed in 2012, 2013. We only had 28 overdoses. Doesn't mean that there wasn't some addiction. Then our numbers skyrocketed in, you know, 16, 17, 18, 162, 170, 180. And I'm happy to say that our numbers are down again in 20. We were down like 31 overdoses that we responded to. So we must be doing something right, or again, we may not even be finding out about these because now that Narcan's available. But as far as, you know, I'd be open to a conversation to hearing more and talking to some doctors and getting some more facts.
No, thank you very much. Lieutenant Simon, or actually anybody, you know, one of the things I found as a chief is that there's a really wide range of knowledge about addiction. And when you go to the academy and you start talking to experienced cops, they tell you you're going to be dealing with, they'll use the term, you're going to be dealing with addicts, right? You're going to be dealing with people with substance use disorder. This is going to be your day in and day out. And yet beyond that, they don't get very much training about what addiction means, how it manifests, what the treatment might be. What do you think? What level of training, or what would you really want to emphasize in training if you were going to teach an academy block of instruction on substance use and addiction? Like, what are we missing, and what kind of gap would you like to see filled?
Well, I just think very plainly, people are broken. People's brains are broken. Because I have officers who just say, I can't believe that person overdosed again. I can't believe they relapsed again. Just the way the mind works, the addicted person's mind works, they're not in their right mind. They're not thinking like you or I. And it's tough. It's like to try to, you know, teach these guys and girls that, you know, listen, they're not thinking correctly, and because they just can't fathom how they do this, you know, by choice. But I mean, it's something bigger than them that's taken over them. And, you know, no one wants to be an addict. No one wants to overdose. It's a horrible life. And they'll tell you, and through talking to people, they'll tell you exactly the same thing. But it gets into the, you know, where they get sick and they don't want to get sick. So the trend, they continue, you know, down the road. So it's real. So what I would teach and stress in teaching is just how the addicted person's mind works.
No, it's interesting. Oh, please, Chief. No, by all means.
No, what I think would work too is, and I know it worked with some other things, is to have people like Corey or people like Lenny come in and actually who've lived it and talk about their struggles. And I mean, hear real stories, and not hear it from a police officer. Hear it from these people who have lived the addiction process. And how they've had to claw out of it to get there, and what they do to stay sober each and every day. And I think that would be helpful.
Yeah, and I see a Barbara chimed in and said, thank you. People don't understand how badly it impacts the brain. So I have this, I think, so two things. What Chief Dunn says is very insightful because there is some evidence that exposure to success reduces stigma. So if Lenny, it would be great if there were some old cops in the room who saw Lenny when he was, you're still young Lenny, but we'll call you young Lenny, who saw young Lenny, and then here's Lenny, in a completely different place. Was able to turn things around and now be part of the solution instead of the guy that they're on the lookout for. That I think shows there's evidence that helps. And then also I have a constant debate, Lieutenant Semino, with some instructors about how far to go into the brain science. And, I'm, if I was a fairly cerebral cop, but I think people underestimated police's, number one, desire for that knowledge. And number two, their ability to understand it. Like, I think, it's literally brain science, but it's not that hard to understand that there's a receptor. It gets a chemical on it. The chemical makes you feel like you're wonderful. You don't get it anymore. You start craving it, and it changes the way you think, right? So it's interesting to figure out the right balance of how much science we should give cops, but I don't think we're giving them enough yet. So I agree with you on that. And I guess in the time left, I wanted to maybe talk for 1 or 2 quick minutes about needles. Right. There's a movement in Indiana right now in Scott County to shut down the syringe exchange. Scott County had a huge spike in HIV a few years back. They opened the syringe exchange and brought it under control. And now the politicians are literally saying, we don't need the syringe exchange anymore. We got it under control. Can you share some insights into how cops might feel about syringes, about, in my opinion anyway, if a person knows he's allowed to have a syringe, and he sees a cop, he's not going to throw it on the ground. He's not going to lie to the cop and hope he doesn't find it. Maybe the cop gets stuck. If there is something you could share, any of you, about how police should approach syringe possession, legal or not, I think that would be a good way to end this.
Well, I'd like to say syringes have been our worst nightmare just because we've had a lot of officers injured being poked by syringes, either in a pocket or in a bag, or just in general handling. Even when, we've had an officer, one time that was being very careful and ended up getting stuck anyway. As far as, responsibly, we do have the AIDS support network in town who does offer a needle exchange, and they also patrol the town and pick up needles that are on the ground. We haven't had a huge influx of needles being discarded. I think that problem is getting better, and maybe it's, attributed to them because they do a lot of outreach work, and they do actually ask us, where the hot spots are, where the, if needles are being dumped, they'll actually go and pick them up for us. We did have a program, prior to that, where someone reported it to the town. We'd have an officer, we'd have sharp containers in the trunk and go collect them ourselves, or the DPW was involved. And the fire department does receive needles. Any needles that we give, they will take for us. So, I'm not, as far as the legalization, it's a little above my pay grade, but as far as, if you're going to carry a needle, please be responsible with it. Do not throw it on the ground, because we were, for a while that we were finding them in parking lots and parks, and there's just no need for that. Just be responsible with your needles. They are legal to have, but just be responsible.
Yeah, no, one of the things we hear is that people who use drugs discard their needles out of fear of encountering the police with a needle on them, or they don't tell the officer they have the needle because they're hoping maybe it won't result in a frisk and no one will be the wiser. And I think ultimately, the irony is that puts the cops in more danger of getting stuck. So I guess that brings us up on the end of the hour. This is a real pleasure. At the end of July, I'll be in Falmouth, actually. So maybe I'll stop in and say hello.
Please do.
Yeah, no, by all means, it's great. So Lenny, Michael Semino, and Chief Dunn, thank you for your service. Thank you for being part of the solution. It was a pleasure to have this conversation, and be safe.
Thank you.
Thanks. Thank you.
Thank you.
Thank you, Brandon. I really appreciate your comments and questions, and also a special thanks to Mike Semino, Lieutenant Semino, Chief Dunn, and Lenny Cardozo, who's doing great work. One thing I didn't mention is that everything that Lenny is doing in Falmouth, he's also doing it pretty much everywhere else all over the Cape, and off Cape as well in Plymouth. So Lenny has a really extraordinary impact, I think, in this area. So thank you also to Lenny. Great. Thank you all for coming. I would ask the next panel if you could turn on your, unmute yourselves and turn on your cameras. I'm looking for Mike Duarte, who was to give a community impact statement as the president of the Portuguese American Association. I don't see him on the line. I've sent him a couple messages. I don't know if he's a problem getting on, but we will start with our next panel in any event. Dr. Rich will be moderating the discussion in this panel, and I'll give you a quick introduction of the people who are on it. We have Dr. Jeffrey Siegert, who is an MD and a surgeon at Falmouth Hospital, has done a tremendous amount of work with trauma patients, and he in emergency services as well, and he'll be speaking with us first. We also have Dan Gates, who is the president and CEO of the AIDS Support Group of Cape Cod, an organization that's been around for a long time in the area. Had a key and very important role with HIV, helping with the HIV epidemic. And he will also be speaking with Tanya Coley, who is an MHA and Director of Prevention and Screening for AIDS Support Group of Cape Cod also. And then finally, we have Kevin Ralph, who is the Chief Development and External Relations Officer of Gosnold, where Lenny Cardoza works. And he will be speaking to us about what Gosnold, the services that Gosnold has, and how his perspective on his very interesting perspective on the crisis from his point of view. So why don't we start off with Dr. Siegert and Dr. Rich? Feel free to jump in and moderate as you will. Thank you very much for coming and for being here. Good.
Take it away, Dr. Siegert.
Well, I appreciate your time, everybody. You know, from a trauma perspective, opioids paint a broad stroke throughout the health system. For the obvious things, violence incited by it. Also, people falling asleep at the wheel, flipping their car, getting ejected. But not only that, you also have, that's more, you would see that more up in the city, more the direct violence from the dealers. But I find down here, what I see more are just awful cases of patients using dirty needles and getting horrific infections and coming into the ER here septic all the time. And on top of that, you have a lot of patients who are just chronically taking opioids, and they may not be injecting it with the needle. They may just be taking a lot of pills. They're pretty easy to get. And so when they come in the hospital with a regular problem, it's generally, 5 times worse than it has to be. And they're presenting with advanced diseases that otherwise you would have noticed, but they've been blunting their pain with drugs. So it's not just one thing. It's pretty much everything. Every day we have to deal with it in one way or another. So any thoughts people have to solving this problem in this town, would love to hear. And if you have any questions, shoot them.
I guess one of the main things that I hear from patients a lot is a reluctance to go to seek healthcare because of how they they perceive they're treated or how they are treated. And so some of that, people coming in with advanced stages of the disease process, maybe from the opioids blunting it, but some of it may be just they're told things like you're stupid and why would you do that, and you shouldn't do that. If they come in and they say, oh, the cat scratched my arm and I have an abscess, oh, you poor thing, let's get you pain controlled, let's take care of you. If they come in and say, well, I had a miss and I hit it, they're treated very, very differently.
That's an amazing point. Because I made the conscious decision a while ago to treat it as a disease, because I know a lot of colleagues that it's hard treat patients who are, they're doing everything they can, and then 2 minutes later they're walking out of the hospital injecting themselves, undoing what you just spent a week trying to fix, and it's heartbreaking. But to me, the alternative of giving up is worse. Personally, I feel like it's part of our oath that we took. So if you look at it as a disease and not as some person just trying to annoy you or ruin your night, or, it's almost a lot of times when you're dealing with these patients, it's like dealing with your 3-year-old kid when they're under the influence and they're jonesing, so to speak. But if you look at it as a disease process, I find it's easier. And every now and then it does pay off. I mean, I had this experience in this very town where I had a patient, and for me personally, I thought she was just going to be dead within a year for all the things that she had. And I ran into her at the store, and she was working, and I didn't even recognize her. She came up to me. So, it's worth it for that. And, but it is hard. I do have a lot of colleagues who have a lot of trouble with, we all have trouble with it. But if you look at it as a disease and take the personal component out of it, I think it makes it easier.
Some emergency departments are having success operating as a low threshold entry point into medications for opioid use disorder, prescribing buprenorphine and connecting people to methadone programs. Is that, are you having much success with that in Falmouth?
I see a lot. I'm not sure what the ER does, but actually it is hard right now with the pandemic. It's hard to get anyone a doctor, and it is extremely hard to get patients into what you may call a Suboxone clinic, or because that's actually a special license to prescribe, which, I don't even have that. But it's really tough to do that.
Okay. I would point out that the Biden administration just a few weeks ago relaxed that requirement for a data waiver training for up to 30 patients. So you don't need to do the training, just sign up.
I didn't know that.
And come on in, the water's warm.
Okay, 30 days, go nuts.
Up to 30 patients.
Oh, 30
patients, yeah. And if you need more, then you do the training, but we can connect you. And I found that prescribing buprenorphine, I'm an infectious disease doctor, and I take care of patients. They say, come back and say, hey, thanks a lot, doc. You cured my urinary tract infection. But when I get someone started on buprenorphine, Suboxone, they come back and they say, doc, you gave me my life back. You gave me my family back, my work. I can function now. It's really life-saving treatment. And it's from a prescriber's perspective, it's just wonderful to see that experience of seeing the woman working behind the counter in the grocery store is just, that's the norm in starting people on buprenorphine. So unfortunately, 90% of physicians across the nation, more than 90%, have had 20 years opportunity to prescribe buprenorphine and have decided not to. So we have a little challenge there. Okay, we should probably move on to the next. And I don't know if Miguel, you had an idea of who should go next, but I guess Kevin, Ralph, do you want to go ahead?
Yes, now that I've unmuted myself. Sorry about that. So hi, everyone. Miguel already mentioned Kevin Ralph from Gosnold, actually a stone's throw away from Dr. Siegert. Literally, a few hundred yards our facilities are located in terms of our main treatment center in Falmouth. So we see a lot of, there's a lot of crossover, we'll say, between the hospital and Gosnold. And I'll mention in a minute, we actually have members of our team, and Lenny can speak to this as well, that or he may have already in one of the other sessions, but who work in the emergency room as recovery navigators, which has been a really impactful program for us. But just a quick overview of Gosnold. So we are an addiction treatment center and behavioral health care center as well. We've been around. We're coming up on our 50-year anniversary in 2022. So we're not too far away from that, which is a great milestone for us. In terms of, obviously, as it has been for everyone, it's been a challenging year. We've been dealing, we're in terms of our own facility and the care that we deliver, our beds are virtually always full. And that included during the pandemic, except for a few brief periods where we had to suspend new admissions as we navigated the COVID issue and with testing, and now finally vaccinations, which we've been able to distribute as well. So that's been a positive, but it's been challenging. Again, the increase in isolation and depression and anxiety have really, we've seen a spike in the patients coming in for opioid use disorder. And I know we're not here to talk about this other piece, but alcohol remains our number one problem when you look at our top 5 diagnoses that our patients have when they come through Gosnold. So number 1, alcohol; 2, depressive disorder; opioids are 3, then anxiety and bipolar disorder. So there's just so much crossover on the dual diagnosis side that we're dealing with, and a real shortage in beds in terms of where folks can go for psychiatric care. So that's something we're addressing now in our planning and our strategic planning. So we hope to have some news about that at some point soon too. In terms of our care delivery, like I said, our beds are almost always at capacity for detox and for our residential treatment. We did move to telehealth though really, really quickly, which was something we had already had in place. So it was relatively easy for us to make that transition in terms of the telehealth for counseling, for our partial hospitalization program, our intensive outpatient program. So that was, now that telehealth is reimbursable at the same level as other care delivery, it's really important for us and for our field in behavioral health and addiction treatment. So I guess I can open up. There's a lot I can talk about. I don't want to occupy the whole intro period here. So I'm happy to answer questions though.
Well, Kevin, that's your point about the telehealth. That is an emergency ruling, and it's a temporary so far. But I think the experience is universal. It's true for mental illness,
right?
But for buprenorphine prescribing,
Right.
It's been invaluable in many places. And as we heard earlier today from Tracy Green, there's been a dramatic increase in overdose deaths with the pandemic, and so that is something that is critical, life-saving, to get easy access to buprenorphine and retention and treatment.
Mm-hmm.
Are you doing much telephone buprenorphine at Gosnold?
No, not in terms of prescribing right now as part of the telehealth. That's mostly, and those are mostly the patients we see in person anyway. While we have 11 facilities around Massachusetts, mostly on the eastern piece, a part of the state, but our treatment center in Falmouth and our residential treatment in Catalmet, those are our primary facilities in terms of where we actually have patients in beds. Excuse me.
Okay, so we should move on to AIDS support group of Cape Cod. And I don't know if Dan or Tanya want to go first. Dan, you want to?
Dr. Rich. Hi, everybody. I'm Dan Gates. I'm from the AIDS support group of Cape Cod. Before we jump in, I just wanted to say this forum today is really fantastic, and I think it speaks to the importance of community partnerships. A town that has a forum like this with this many community partners involved, and a chief of police and lieutenant who take the time to really talk about the nuances of this, I think we're very lucky. I also would like to say that today is the 40th anniversary of the first case of HIV. So I thought we should just acknowledge that. That is the root of our work, as you guys know, and as Miguel mentioned. We're grateful to be here today. And I'm going to hand this over to Tanya Coley, who is the Director of Prevention and Screening for us at the AIDS Support Group of Cape Cod. But thanks again for having me. I'm happy to be here.
Thank you, Dan. Good evening, everyone. Hi, my name is Tanya Coley. I am, as Dan mentioned, the Director for Prevention and Screening at AIDS Support Group of Cape Cod. It's good to be here, and it's good to be a part of this discussion with everyone. So the prevention and screening programs at ASG, they're a core function of the work that we do, and they fulfill a very essential part of our agency's mission. Our agency's work, it provides prevention, education, life-sustaining services that address public health crises to build healthier communities across Cape and the islands. A little brief overview about our agency's history. I know Miguel mentioned it a little bit, but so AIDS Support Group was founded in Provincetown, Massachusetts in the year 1983, and by community members who joined hands to respond to the emerging AIDS epidemic. Currently, ASG serves over 400 clients living with HIV across Cape and the islands, with offices that we have in Provincetown, we have an office in Hyannis, in Falmouth, Martha's Vineyard, and we also have 2 mobile van units. There's another public health crisis that we're here to talk about today, where our staff's expertise and skill set is needed, the opioid epidemic. For close to 2 decades, the opioid epidemic, it has consumed Cape Cod and the islands, and as a result, hundreds of our family members and community members on the Cape have died. In Falmouth alone, in between the years 2015 and 2020, we have confirmed 88 opioid-related overdose deaths. On Cape Cod, opioid deaths now represent the fastest growing cause of death in Massachusetts since the initial AIDS crisis of 80s and 90s. And throughout the epidemic, our organization, we've continued its key role in fighting to save lives. So some may also ask, why is it that an AIDS organization is fighting a drug epidemic? The answer lies in our belief in the principles of harm reduction and the agency's commitment to prevent transmission of HIV and other sexually transmitted infections. ASG is one of the 20 community-based agencies participating in the Massachusetts Overdose Prevention Initiative, a program which was created by the Bureau of Substance Abuse and Services at the Massachusetts Department of Public Health. And as a part of our agency's mission, which is based in harm reduction philosophy, ASG has established 2 public health programs: syringe services access and overdose education and Narcan training, to give people who inject drugs a chance to empower themselves while they make informed decisions, reduce risk for themselves and others, and in some cases, stay alive long enough to get supports and help they may choose to seek. These programs, they were once considered controversial. Excuse me, I think I have...
Somebody's on fire.
Yeah, my fire alarms are going on.
Tanya, I can take over for a second if you want to deal with your fire alarms.
Yeah, so I'm really sorry about this. I'm just going to come back and see what's going on.
Well, please.
Thank you, Dan.
If you have to run, run.
So everyone, I'll just, I can't speak nearly as eloquently about this as Tanya could, but I will say, the harm reduction philosophy is deeply rooted in the work we do. And there was something that we were saying right at the beginning of this segment, I think Dr. Siegert was saying it, about the a lot of the people we're serving in this time have been disconnected from the medical care system. And so one of the benefits of our work at the AIDS Support Group is we are very much founded in meeting people where they are at. And we often become the gateway into the medical care system, because a lot of people, because of stigma and discrimination, have fallen out of the system. I think it was the last panel people were talking, and I think someone was asking about, what could be done to improve engagement within the healthcare. And one of the things to think about is sometimes we have organizations who our intentions are well-meaning, and some of our policies don't fit all of the populations we work with. So for instance, if we have policies at our organizations that if someone doesn't show up for an appointment, that they then lose access to that healthcare provider for a certain amount of time, that's something we have to adjust, because we're working with a population that if you are in the throes of any sort of addiction, it is understandable that you might not be able to show up for appointments as regularly as you'd like to. And so you have to come up with kind of innovative ways to engage people. So one of the things we do is we have a program called short-term health navigation. And that is a program that takes people who, they may walk through our doors for an HIV test, they may come in for Narcan access, they may come in and ask to use our mobile outreach van for access to sterile syringes and sharps containers to dispose of their syringes. In that moment, we can talk to them. And if they are looking for some of the medication treatment that people have mentioned today, we then have a worker who kind of navigates them through that system and helps them achieve some of the things they might need to do to access that appointment, maintain that appointment, remove barriers of transportation, etc. I see Tanya's back, and I'm thinking the crisis may have been averted, so I will stop now.
Yeah,
that's great. I just wanted to latch onto that notion of people coming through, and you might connect them to a treatment with buprenorphine, Suboxone. In Rhode Island, we have actually created, using this telemedicine, a hotline where you could actually, at your office or at the van, call up the doctor on the hotline, put them on with the patient, and the doctor would call the prescription right to the pharmacy and go and start right away. So that's another harm reduction. Low threshold buprenorphine is really something that is available now, and hopefully we can continue that. So,
Dr. Rich, I think you're really hitting something that I think is one of the more effective interventions you can do. We're doing similar in some of the towns on the Cape. And it's there aren't a whole lot of positives that have come out of COVID, but as I think you were mentioning earlier, the access to telehealth and the lessening of some of the governmental restrictions to providing these services is something we should try to advocate to continue.
Sorry, Tanya.
No, I'm sorry. I'm not sure what happened, but thank you all for understanding. As we were just talking about, that we do have 2 mobile van units on the Cape that we have community members who can come onto the mobile van units. We have the addresses posted on our Facebook page that the mobile van is going to be at. So instead, if somebody they're having trouble getting to our offices, we can come to them. That's why we have the mobile van units. We can help them get appointments, help them get access for referrals to MOUD or referrals to healthcare services, mental health services. So we have those, and even for our syringe services access, our mobile van unit is something that we are able to offer. Fortunately, offer that out of the mobile van unit in Falmouth as well. So.
I'm kind of wondering, sort of basic questions about services needed and services available and rendered, and in Falmouth in particular. So I don't even know what the population of Falmouth is, and how many people with HIV, and how many people with drug injection and with opioid use disorder. then how many people are, is there even methadone available in Falmouth? And then how many buprenorphine prescribers? There was mention of, I think Dr. Siegert said it's very hard to get people into a buprenorphine clinic or prescriber. And then the syringe services you guys are offering, how many patients are you getting to, and is there, do you feel like you're providing enough services? Or because Dr. Siegert was talking about people injecting with the dirty syringes, and is there pharmacy access to syringes as well? Or are people, it being a small town, people may be reluctant to go in and buy syringes at a pharmacy. And maybe if you can give us a sense of what it's like at the needle exchange services you're providing. Are people, kind of skulking in, sneaking in, or are they proud to go there and happy to, and referring their friends?
Yeah. So for the Falmouth office, we currently do not provide services out of our brick and mortar Falmouth service offices just for syringe services. We only utilize our mobile van unit. So we partner with other community partners that allow us to park our van on their sites, and we are able to offer all of our harm reduction services, including syringe services, out of their site. So the way it works is when we go to their site, we park our van, we have our boat outside, and our short-term health navigator and our harm reduction specialists, they're standing outside, and they're engaging with community members, and they're talking to them about what sort of services that we offer. And the conversations and the way that it happens, that it's very inclusive. It's in a non-judgmental manner. It's not that. So yeah, that's our van. So yeah, the conversation starts, and that's how folks they get aware of what we offer, and they come on board. We ask them for however many needles or syringes they need, and we provide them with sterile syringes. And if in that moment, if they have any used syringes, we do collect them. We have shops container on the van. We also have a kiosk for shops disposal on our site. So we, if in that moment they do not have the used syringes with them, we offer to pick up the used syringes from their house or whatever site they tell us. So we do offer those services. So yeah, it's again, it's something that's I have seen the harm reduction specialists, we have those conversations. It's not something that, it's awkward, or it's something that, it's something that's, it's uncomfortable. It's very much a part of the conversation. And we constantly ask them, do you need anything else? Do you need, we always make sure we give them alcohol wipes. We give them other supplies that folks might need when they're using syringes.
You have a sense of how many syringes, how many clients, and then how much the need is in Falmouth?
So for the town of Falmouth, on an average, if I look at monthly data, we have 6 to 7 participant encounters on our van each month. And the number of sterile and used syringes, it changes every month. So I think so. Usually, historically, with agencies, syringe services program, we've had an average of collecting 20% more syringes than we distribute. But an unexpected thing happened during COVID. The collection rates dropped, but we anticipate making that up now that people are out and about more.
And Tanya, I should add for Dr. Rich and for some of the other panelists here. So our program launched during COVID. So our numbers are a little bit tricky because of the challenges of working with finding partnerships where we could locate the van during COVID, right? Because a lot of the, like, for instance, a church will reach out and want to work with us, but during COVID, they had limitations that they couldn't really be bringing people onto their sites while we were in so many lockdowns. So I anticipate when hopefully we have this panel a year from now, and hopefully everything's going really well with the vaccination process, we will have a lot more numbers to share with the team. I can tell you for in similar towns on the Cape, there can be, 100,000 syringes done in a year. And then usually at about that rate, we would collect approximately 115 to 120,000. So we take in far more than we give out, as Tanya was indicating. And I'd also like to add one thing, if I could, just when you think about the stigma of this, I'd like to share that I think Falmouth, again, like this panel is really showing how people are invested in this. In Provincetown, we have the oldest syringe program in the state. There were two in 1995, one in Cambridge, one in Provincetown. And our Provincetown location is on Commercial Street, right there in the middle of the tourism. And we do full services there, and there is a pride in people taking care of their health, whether that's an HIV test or syringe services. So it's something for us to think about as we go forward, because the stigma is a big component of keeping people from accessing services.
Okay, well, that's, I still don't have a sense of what the need is. I think 6 to 7 clients per week is obviously a very low number. But launching during COVID is hard to. I was involved in starting up some needle exchange programs in Providence, and when you first start, it can be very, very slow, and it's usually once people show up and they find out what you're doing and they like what the people there and they like what's going on, then word of mouth spreads and then it can increase. But we, I have to say, in Rhode Island, we never really got to the large numbers of syringes distributed as many other syringe programs, and I think part of that was we had a strong effort to educate the pharmacists and get people into pharmacies, and they're cheap and easily accessible. Are there any questions? I know that Tracy Green gave an excellent comment. To say that we have, during COVID-19, pioneered a program of same-day treatment via pharmacy buprenorphine access. So this is actually both for withdrawal support and induction, currently available at 6 Genoa pharmacies in Rhode Island. So that's important for our patients, but nationwide, there nearly half the counties in the country don't have a buprenorphine prescriber. So but every county has a pharmacy. So if we can move this low threshold access to buprenorphine into pharmacies, that's going to make a huge difference in many places. Great. Any questions?
I have a question, actually, or actually just I would ask Dr. Siegert if you could maybe talk a little bit about your experience with cultural relativism of pain management, and your thoughts on on what pain means and how this can affect prescriptions of pain medication.
Somehow you're muted.
There we go. Can you hear me now?
Yep.
Yeah, personally, I think one of the worst things we have in medicine is the pain scale.
Yeah, guess who gave us that? Thank you, Purdue Pharma.
Right. Well, yeah, it's not a vital sign. But the importance of it, or having it so upfront, means that when you get a call at night or anywhere in the hospital, it's someone's at a 10 out of 10 pain, and it's so easy to just click a button or tell a nurse, hey, give them a couple oxys or whatever. And it's amazing to me how much pain meds that Americans suck up. And when you go to another country and operate, it's like, you can do a huge operation. You may give them a couple milligrams of morphine during the first night after a chest wall resection. And then after that, it's just Tylenol, because that's all there is. And no one seems to be very upset by this. They actually get out of the hospital faster. The problem with giving, our reliance on opioids is that I feel like it's much worse care. People, have a hard time, longer length of stays in the hospital. They do worse. But the expectation put on the providers is to be giving it out all the time, to make that pain, knock it down to a 6 or 5. And really what needs to happen is just, education of the patients before surgery, or before coming into the hospital, that, you're going to be in pain. And the answer isn't always just couple shots of morphine or oxycodone, because that, I see this all the time. When I started training, I was told just give people like 60 tabs of Dilaudid, because then your attending won't get called, because if your attending gets called, you're going to get in trouble. Right? That's how I was taught, and it was totally wrong. Now I'm pretty chintzy with this, with things. But I feel it's interesting, culturally, that's a very Western notion, that you have to just lay in bed and just, sit there like a beached whale, just getting pain meds. And that's what hospital care is supposed to be. And you go in any other of these countries, especially in the third world, where they don't have access to this stuff, then you realize how wrong we have it.
I fighting all the time, including every day, how to get the patients out of bed. I have an 85-year-old patient in the hospital now. I went and saw him, and I said, "Well, can we take him for a walk?" "Oh, I don't know. The nurse said, "Oh, okay." And so I walked him down the end of the hall and back, and they said, "Oh my God, he can walk. Oh, he shouldn't be laying in bed all the day long." Turn him into something. Tracy Green has another, how do organizations currently interact with law enforcement, and how should that change? So that's a good question for you, Kevin, and for Dan and Tanya.
Yeah, well, that's great. And if Lenny is still on, Lenny, are you there? I see you. Oh, here he is. Lenny, did you hear the question?
Oh, no, I didn't. Go ahead.
Okay. Well, the question was asking how agencies work with the police departments, correct, Dr. Rich?
How do they?
Yeah, and if there's any, how can that be improved if there's friction there?
So Lenny, for those of you who weren't on the previous panel, Lenny is he's the man, right? he's our guy at Gosnold who works arm in arm with the police department. But let me turn it over to him, because he can do a much more.
So what was your question again?
So just wondering if there's, I can look at the way it's written, but it's interaction with, how do the organizations currently interact with law enforcement, and how should that change? Or should that change? And if so, how?
So how do we partner up with the law enforcement?
With law enforcement, and how does law enforcement partner up with the AIDS support group and needle exchange, harm reduction people, and anyone else? Yeah.
That's a tough question. We started working with them in, I believe, 2015, and we approached them, and we came with this model that we wanted to work with them. Lately, like I said, I've been actually talking to Tanya, and we're trying to collaborate with other agencies to bring more people on board to try to figure out a solution. I actually work with the Plymouth County Outreach off Cape, and there with law enforcement, there's many agencies involved. You have the school districts, you have different agencies for health resources. What else? You have the jail system. So it's like one program. They created a hub model, which is, I think what they're trying to bring on Cape. That's for mental health. There's all different agencies that sit upon this panel, and they all come together and we share information, which helps out a lot. But like I said, it's not just one agency. You need many agencies to work to this to help offset what's going on.
So I'm looking at Falmouth thinking, and as I mentioned earlier, I have personal ties to Falmouth, spending most of my summers there. I'm wondering, what's the scope of the problem here? I'm not hearing that we know how many people have a drug problem, how many people have HIV, how many people have an opioid problem, how many people are injecting. I think from that, then you can say, okay, so, and how many people are getting the services they need, and how many people are not, and where are the gaps? What do we need? Do we need more needle exchange? Do we need more low threshold buprenorphine? Do we need more bupe prescribers? Do we need a methadone program? And how many people what are the touch points? So do people interact with you got your knocking on the door program? That's great. Now, what proportion are you getting there? How many are getting involved in the criminal justice system, either being arrested or interacting with the police or on probation, parole, or in the jail? And how many are coming through the emergency department? How many coming through the hospital? Just thinking through different touch points of where is this population circulating, and where are there gaps where you could actually give services, like how much Narcan is out there, and then the ambulance, the rescue runs, and of the how good if there's enough Narcan, you would expect that every ambulance run would have for an overdose, would say, well, okay, when they got there, somebody had given them Narcan. So if that's 90% of it, then you probably have enough Narcan out there. If nobody's getting Narcan before the ambulance gets there, you probably don't have enough Narcan.
Yeah, Dr. Rich, I would say the measure that one of the measures you listed there is a really important one, which is the ER calls for overdoses. So now, forgive me, my data on this is from before COVID, but the data we had was that Falmouth had a rate of a town 3 times its size for calls for overdoses. So the state of Massachusetts identified Falmouth as one of the priority towns to focus on because of that high rate. Now, fortunately, that overlaps with really good Narcan access. We have both at ASGCC and with community partners really worked with a lot of communities. I think we do about 10 trainings a month, community trainings for Narcan, where we give out free Narcan and a training to everyone who attends that session. But that is one of the measures that shows just how critical the need was. Tanya, I will hand it over to you if you have anything to add about that.
You're muted.
Sorry. Yeah, so the only thing I'm just going to add is that we, Dan, you're right, we do close to 10 to 15 overdose prevention education and Narcan distribution state training every month across all of our sites. And especially for the town of Falmouth, we average around like 8 to 9 trainings every month. And over the last, if you look at the last 1 year, we have given out close to 400 Narcan kits we have distributed in the town of Falmouth.
That's great. That's wonderful. I don't know whether that's enough or not, because I don't know how many people are overdosing and how, and I'm hearing it's 3 times higher than other states in Massachusetts, which I'm not surprised about. So I think, what I'm hearing overall is that, you have a lot of the ingredients here. You have a police force that's, that the chief is engaged and is supportive and is, singing Lenny's praises. You've got, a Cape-wide agency that has identified Falmouth as as a place with need, and you bring in services. You've got a drug treatment facility that is, has many offices, but it's 50 years of history in Falmouth, and you have you have your own hospital. You have a lot going on in Falmouth that a lot of the ingredients to really take a bite out of this epidemic. And I think what I feel is missing is a band leader, someone to kind of galvanize everything and get some basic data about what are the needs, what is the population, what is the needs, and that's not easy data to get. We struggle to get that in. I mean, we've been trying to do this, the governor's task force, for 6 years now, and we're still, and we have a lot of state agencies and researchers and we're still struggling with it. But I think that's, and it doesn't have to be perfect, but I think what you want to do is try and get at the impacted population and try and talk to them and understand where do they go and where do their friends go, what do they perceive as their needs, I think we know what we need to do. We need to get the population that's impacted educated about the nature of this disease, about the treatment for this disease, how the medications are the most effective treatment to stop overdose, and how to reverse an overdose, and how to make sure everybody has Narcan, and how to avoid infections. Now, to me, an AIDS service agency working on overdose prevention and injection drug use is, one of the very first cases of AIDS. One of the first 5 cases was somebody who had injected drugs. This has been from the very get-go a major risk factor. And who else but people who are familiar with dealing with HIV is going to dive in on this. So that's a natural to me. But I think some kind of putting some heads together and getting an assessment and understanding of how this is. And I like what Lenny was saying about the Plymouth-wide, because you get the school systems involved, you get all these different agencies. People are seeing this all from different perspectives, and as you get everybody's perspective in the same room, you start to get an understanding of what the magnitude of the problem is. And you'll never get a perfect understanding of how many people are impacted, but you can get a rough estimate, and that's enough to work with to kind of make some estimates of, oh, geez, we're giving 6 or 7 people a week. We actually should be doing 60 or 70 people, or maybe that's enough. I don't know. Maybe 400 Narcan sounds like a lot. Maybe that is a lot, or maybe it's not. I don't know. The police, I don't know how many people are arresting. I don't know how many doors, Lenny, you're knocking on, but I think getting an understanding of what these various interventions can do, and how many people are coming into Gosnold from Falmouth and coming out to Falmouth, and what's happening to them after they get out. I think all of those are the kind of questions everybody should be asking.
And we have a lot of that information that you just talked about. We have a great quality director who he'd love to be on this call right now, because he could probably throw up 40 different PowerPoint slides with all of our stats and figures. I can tell you, so last year, just to put a little perspective on our piece, in 2020, we served just under 8,000 patients and clients, and almost 2,000 it was about 1,700 were from Falmouth. So I don't know if that helps in terms of the perspective piece here, but we track obviously primary diagnosis, so where they're going, what their care plans look like, their treatment plans look like. So we have a lot of that information, and there's also a Barnstable County Regional Substance Abuse Council that has representatives from, I'm sure everybody's on one of the committees or subcommittees, right? And a lot of this information, I I've only been on it since this past fall, but it seems as though that's something that we use as a way to share information and communicate more effectively, or try to at least.
So one of the themes that came out of the last two panels was that this really is a disease, not a crime, and really that treating it as a crime, you're not going to get as far as treating it as a disease. And really, to do that, you need to change the culture. And so that's another kind of overarching thing. And Chief Del Pozo talked about his work in Vermont, actually de facto decriminalizing possession of buprenorphine as one of the strategies. So the police chief and the prosecutor said, we're not going to arrest people for possessing buprenorphine if they don't have a prescription, because we see this as treatment and we shouldn't be hindering it. So that kind, having public officials come out and make those kind of statements is part of how you get the culture change. You get the discussion, and you get people to start thinking about, well, okay, so we should be treating people and not arresting them for drug use. So, okay. That's changing the culture and ending the stigma is what Barbara Burgo has been doing for 50 years. Barbara, do you want to, I don't know, can we unmute you and tell us a little more about that?
I'm unmuted. I thank you for all of this. I'm supposed to be Miguel's 5 o'clock speaker, so I don't want to, alter any of what I had to say for that, because I really had a presentation. But what I didn't say in this is that my first brother first attempted suicide in 1967, right out of high school. I know he used marijuana. I don't know what else back then, because it was such dark ages, I've also mentioned to Miguel, what I didn't say in my speech is that part of it was due to race. So those are the things that I'm listening to and I'm paying attention to. We're Cape Verdean, as most of all of you know here, especially Rhode Island and Massachusetts. And he could quote unquote pass when he was younger. And he did, but getting out of high school, it impacted him severely. So he was diagnosed with schizophrenia and sent into Taunton State Hospital. And again, the dark ages, it was changing the stigma. When I was in high school, they called me, I was 2 years younger than him. They called me the sister of the guy in the nut house. I listened to this, and I've been on here for the 3 hours because I was 16 years old when he first attempted, and living as a Black female in Taunton with a 92% white population at a school where I had a brother in Taunton State Hospital. It was horrific growing up. Not only with the lack of understanding of all of this, but with back then, you folks will know it more than me. He had things like Thorazine and Meloril and shock treatments. And one of my friends, a distant cousin, said mostly they kept him sedated because he was a big Black man and they were afraid of him. And this was a man who worked there. So changing the culture, the way everyone thinks and feels about folks like my brother, has been important to me. I'm going to be 70 years old on June 19th, the Juneteenth baby, and I see very little change. I applaud Miguel and everyone else who is on here because it helps me heal. I'm still healing, because every time I hear these things, I pay attention to these programs, because incrementally things have changed. I hear it, I see it. For me, in 50 years, nowhere near enough.
Thank you. Thank you so much, Barbara. That, and we look forward to your comments on the next panel. Tracy, you were just making another point. Do you want to tell us about that? Or
sure. Yeah, I was just mentioning about the opportunities. We're just hearing from Dan and Tanya around some really neat programming on case management and patient navigation and incorporating a lot of harm reduction activities alongside them and incorporating medical care, connecting people to buprenorphine. Seems like there's a lot of cross-pollination, if you will, in the harm reduction setting with medical care. And I was curious for Dr. Siegert, and some of the things I've been sort of starting to see are opportunities where potentially, and maybe there are, or maybe there aren't, but I'd love to hear your thoughts on how to bring more harm reduction into the hospital and probably especially the ED setting, but probably in the inpatient side too. What opportunities are there for more harm reduction in the healthcare setting?
Well, on the inpatient side, there's plenty of space because there really is no harm reduction. I think the real push is to funnel patients from the ER over to Gosnold, where most of that would happen, and probably less so in the emergency room. So yeah, there's a huge opportunity there for sure.
Great.
You know, one of the things that they do that sometimes also helps, Tracy, I don't know if this speaks to what you had in mind, but also the post-overdose work that can happen where ASG does some of this. I know Gosnold does some of this, where there are working with local officials and actually following up with people after they have had an ER visit for an overdose and checking in to see how they're doing that way and reconnecting them to care if that's of use. Also, and there are some unique, Tracy, I'd be happy to chat with you about it sometime. There's a partnership ASG has done with Duffy Health Center, which has been really a really nice hybrid of the harm reduction work connected to a short-term health navigator who then connects to a medical care person at Duffy Health and doing kind of a wraparound system like that.
Great. Well, I think we just have a few more minutes. I perhaps I was going to ask a little more about the interaction with the police, kind of growing from the last session, that program, but I don't see our Lenny on. There he is. So Lenny, I wonder, what are the typical circumstances that you'll go do a knock? How many times do you knock on the door? How long does it take you to get? And then what happens when you do get in the door? And maybe you tell us what that's like typically.
Well, I've been doing it for about 6 years. I've probably done over 1,000 follow-ups. Each town is different. So each town has its difficulties. Falmouth is a different community. Like I heard somebody saying, like, what are the catches and like what do you have to change? Falmouth's not too bad of an area. I'm able to locate some people around here because it's a recovery community. There's like over 60 sober houses. So a lot of the people I'm able to find, or not all of them, but I mean, have better success in the Falmouth area of getting people into treatment or making an engagement when I do a door knock, versus Barnstable, Hyannis area. That's more of a homeless community because that's where the shelter is at, and those people are hard to find. So we go out there, we do the follow-up. Sometimes we're not even able to do the follow-up because there's no address to go to. And where the communities in Barnstable are different because there's a lot of hot spots and they're jumping from place to place. So when I do go to do the follow-up, I can't locate them because they're no longer at the drug spot that they were in. Versus where Falmouth's a little more, it's an easier catch. Some people, where I work with the Plymouth County outreach off Cape, they've created a system which we created on the Cape, which is a Barnstable County outreach now. Some people will entail where they have like tier 1, tier 2, tier 3, and like, one person has a certain overdose, we will do a follow-up. And sometimes when they hit a tier 2 where they're having multiple overdoses, it'll call for more visits for that person. And sometimes, on Plymouth County, they'll get a phone number. These people will get phone calls every 30 days to see what's going on, to see what more treatment they can offer them, to see where they're at. This population is a tough population because the people we're dealing with aren't looking for treatment. They're inactive. So to convince them or to talk to them to get into treatment is a tough thing. I do give out Narcan, I do give out resources, information, and harm reduction stuff, that can help them. But like you said, meeting them where they're at is the toughest thing, you know what I mean? Because they're not ready, or some are ready. But depending on the town and the location, I think that plays a part of how we find them. And I believe like those in danger of overdosing 3, 4, 5 times without any treatment, sometimes I believe the law enforcement somebody has to enact, like, they have to be a Section 35 sometimes, off Cape, they'll do this. Because if the family's not being involved and this person's having multiple overdoses and nobody's advocating for them, sometimes a Section 35 is good because you need to save that person before they kill themselves. So.
And have you seen that work in the long run in anybody? Is that
off Cape? They do. They're on board off Cape, Plymouth County. Depending on what towns you're in, a lot of the judges are on board with it, and it's easier to get people off Cape, Section 35. Due to what's going on. But like, there's a stigma around it. In different towns. Cape's a little different. Some of the police stations don't want to Section 35 people because there's a stigma. If this is my 3rd or 4th overdose, I may not call and report an overdose because I could get sectioned. So some police stations stay away from it. But I mean, it does work in certain circumstances, I believe, because I believe if nobody's advocating for that person, where somebody has to step in. So it's a tough line where it does work, where versus the stigma comes. But I mean, it gets tiring when you go to the same house and you've seen a person 6 times in 2 years and nothing's being done. You know what I mean? Whether, like I said, they're living on the streets or they're just in limbo. And it comes down to insurance too. Sometimes they can't get more insurance. They may have mass health where it only covers 3 to 7 days and there's no more aftercare. So like, what are we doing? If we can't get them further care, like, are we helping the program? Are we helping the process by getting them into detox or getting them clean? They're just more susceptible to overdose and die.
I would just point out that detox for opioid use disorder is really an antiquated idea. What happens in detox is people lose their tolerance. So when they leave, they're more set up to overdose.
Yeah, really, that's why.
Yep. They should be converted to getting people onto either methadone, buprenorphine, or
MAT, or something, Because like I said, if you can't get further care, it's like it's a tough,
right.
It's a tough avenue.
Now, do you think that would be helpful if when you're knocking on the door, you said, "Hey, by the way, I can call a doctor right now, and he can send a prescription to the drugstore across the street to get you started on buprenorphine"? Would you be interested in, if you had that?
Well, if I had the resources, and I had that avenue, then that could be something different. You know what I mean?
You think people might be interested in that?
I'm pretty sure. I mean, if somebody knocked on my door 15 years ago and said, "Hey, we have some options, we can help you out," I'm gonna listen. I'm on board. You know what I mean? Information.
It's more of an option right now. It's not like, "Oh, we'll get you an appointment next week."
Yeah.
It's like, I can get you a call right now.
Yeah, if that's what they need, that could be successful. Yeah. That door knock with that opportunity. I mean, information. A lot of people stay in limbo because they can't get it, and it's like 2 weeks down the line, or they don't have the capacity to figure it out. But yeah, I'm pretty sure like that'd be great.
My experience has been there's a window of opportunity, and that window opens. And if you don't jump on it, it closes right away.
They usually say with the follow-up, for anything, it's 24 to 48 hours. You want to try to catch them after they have that interaction. So whether it's in the post-overdose with the AIDS support group or post-overdose with Gosnell, you want to get in that window, because once you get to 3, 4, 5, 6 days out, the desire and the changes, they're already off and running.
Yeah. Well, they're off and running, but those, the truth of the matter is, it's no fun being strung out on drugs. It is a hard job, on opiates particularly. It is, you don't get a days, nights, weekends off. It's 365, no holidays. And those windows of opportunities, they open and then they close quickly. but they're opening and closing all the time because there's always this ambivalence about, gee, do I really want to use? So having someone like you on the front lines that has access to low threshold buprenorphine, I think is key. And of course, that's got to be backed up by, real access to real treatment further on and further services. But I think our hour has come to an end. And I just want to thank all of you for all the work that you do and for joining us this afternoon. This is really, really great to get all your input. So keep up the good work.
Thank you, Dr. Rich, and also thank you to this great panel. This was really interesting, and also from speaking to you all prior to today's event, I've really learned so much about the really important work that you all do and the efforts that you make to try and reduce harm in Falmouth and also on the Cape. So thank you all for that as well.
We'd like to invite Barbara Burgo to make some comments. I think if you're still on, I see you.
I thank you. I mentioned earlier that it had been 50 years that I've been researching into this, and this has helped with some answers, but there's still so much more to go. I started with nearly 3 decades ago, about 1991. I received another dreaded call from my mother one sunny fall weekend. I lived in Taunton at the time and was a human resources administrator at Wheaton College. This latest life-altering phone call, of which there were many, Mom called to say that my youngest brother was an inpatient at Fuller Memorial Hospital in Attleboro. And one of the nurses in touch with her since my brother was on suicide watch called to say that he was then on a hunger strike. He had given up. He had not eaten or bathed or even got up in the last 2 days. Robert was about 35 years old and the father of 3 children. He had been suffering for what I thought then was only about a decade long of depression, combating that with self-medicating drugs and alcohol. At the time, Mom was approximately 62 years old and just filed for early retirement from her job that she worked as a Brockton area multi-service night watch person over the folks that were there suffering from mental illness and addiction, just like her son. I answered the phone and heard her low, hesitant voice saying she simply couldn't go. I knew she had called to ask me for another favor, one that still haunts me today. Heart-wrenchingly, my baby brother had apparently given up. She said the nurses had called in a last-ditch attempt that maybe one of us from the family could convince him. Maybe if he saw his mother, that would convince him to get up and want to live again. But she begged, Barbara, please go visit Robert. See what you can do. I cannot go and see him in that condition. She wasn't being cold-hearted or insensitive toward me or Robert. It was true. She couldn't emotionally pull herself to do that. You see, her oldest son, Richard, had committed suicide about 14 years earlier. He had been diagnosed with schizophrenia in 1967 when he first slashed his wrists and was taken for treatment at Taunton State Hospital. His third and last attempt was documented as suicide by hanging. The conductor of a train in East Taunton saw him swinging from a rope in 1978, and he stopped the train just prior to hitting his body, he told my mother. And if he hadn't, there would be no body to bury. Richard had told my mother previously that he knew he was defective. He felt he was defective, did not want to live any longer, and did not want to bring a child into this cruel world. Robert took the loss of Richard, his mentor, extremely hard. His risky behavior became a full-blown addict's life, coupled with suicidal ideation. I felt a mix of anger at my mother for even suggesting that I be the one to go to Fuller and try to get Robert to live again. And pity for the woman who gave us life and was now trying to hold on to her second child that wanted to end it. Reluctantly, I drove, sobbing and yelling all the while. Why was my family trying to commit suicide? Why did they want to die? It could not be happening a second time. Could God be so cruel? Is there a God? When I arrived, it was a pitiful sight. Robert was a previously handsome specimen of a man at nearly 6 feet tall, weighing 280 pounds when he was admitted. Now 20 pounds lighter, feeble, on the bed, facing the wall in a fetal position. I'd had the presence of mind on the way to bring his favorite steak and cheese, thinking I could maybe entice him to eat. Robert said he wouldn't eat. I begged him, Ma, need you here. We need you here. Robert simply said, what's the use? I said, we've got to find out what is happening to this family. We've got to help save the children. There must be some research we can work with that wouldn't allow our children to suffer this fate. But he said, I can't, sis. So with tears streaming down my face, I stood up and kissed him goodbye and walked to the elevator, pushed the button, and a nurse said, look. And I turned around and he was standing up. I convinced him to go into the kitchen with me. We found a box of Rice Krispies. We started eating Snap, Crackle, Pop, reminiscing and enjoying a little bit of his life that I thought was going to continue there. He would be my guinea pig, I said. We'll figure out what this is that's happening to this family. 2 years later, he wrote a suicide note saying that the voices were telling him that he had to do this. It would be the best for the family. He was sleeping on my mother's couch at the time when she heard the screen door close at 5:45 a.m. She got out of bed to hear him screaming in the backyard. Her son had doused himself with gasoline and set himself on fire. He walked to the front window and asked Mom through the bay window if she'd called the fire department. And she said, yes, I already did. She later told me his lips looked like hot dogs on a grill. It was Labor Day weekend. I don't know what set him back that night, but I do know that he had been in program in NA for 7 years. He had a backslide after his 5-year coin and got right back on track again. He said he needed me to visit his therapist with him to make amends, and he showed me the list of drugs that he had used. I saw PCP, heroin, LSD, marijuana, cocaine, and many others I'd never heard before. After his death, I started visiting his psychiatrist to try to get some sense of this. And this is where David really comes into play right here, right today. I said to the psychiatrist, I don't understand what happened that last day. He seemed fine. It's almost like his brain short-circuited. And the psychiatrist said, Barbara, I believe you're right. There are only so many connections in the brain that if they disconnect the synapses, you cannot function any longer. And I think Robert did just what you said. He just short-circuited. My mom died 10 years later of a heart attack on the way driving home from church. She was 73 years old. And that's when I decided I needed to leave Taunton and move on the Cape. And this has been a difficult scene to watch on tape, as I believe it is worse than what I dealt with in Taunton. Thank you.
Thank you, Barbara. That's phenomenal. That's it. It never ceases to just touch me, this story. And this was a very short version of this story of yours. Our next panel is policy perspectives and we're going to be speaking with State Representative Dylan Fernandez, who represents Falmouth, Martha's Vineyard, and Nantucket, as well as David Vieira, who represents Bourne, Falmouth, and Mashpee, and is also the town meeting moderator of Falmouth. One of the great aspects of New England democracy that I talk a lot about in Portugal is the sense of direct representative democracy. This is a little bit different in Falmouth, as we're bigger than some small towns in New Hampshire. So it's not everybody, but we do have a robust, a very robust town representative democracy. And actually, I saw that one of the attendants is Patricia Oshman, who is a recently elected town meeting member. So the most recent. So congratulations to her as well. We also have Tracy Green will be moderating, who you've met a little bit already, and that we've already introduced, the Deputy Director of COBRE. And then also Tammy Gouveia, who has a doctorate in public health. Excuse me. And she's also a Massachusetts State Representative representing Concord, Carlisle, Chelmsford, and Acton. And so we're really grateful and looking forward to hearing what you all have to say from a policy perspective. I guess Dylan Fernandez, Representative Fernandez, will be starting off. So welcome, Representative Fernandez, and you could unmute.
Thanks, Miguel.
There you go.
It's good to be here. Thanks for hosting this forum. Great to see my excellent colleagues, Tammy Gouveia and my partner in Falmouth, David Vieira. So I'll just kind of paint the table on how I see this in Falmouth and some of the statewide trends. And then I'm thinking we'll get into a little bit of legislation that has been filed and legislation that has been passed. So, after, I'm sure it's been discussed earlier today, but after a couple of years of really promising decline, opioid deaths are on the rise again in the state. And, as someone who grew up here, this is an issue that is really personal to me. These deaths are not just statistics. There are neighbors and friends and family members and loved ones. And it manifests itself in Falmouth and across the state with children being raised by grandparents and babies born addicted to the morphine molecule, and mothers and fathers distraught over the loss of a child. And in Falmouth in particular, at East Falmouth Elementary School, 12 parents of children died over a 3-year period. So imagine a child starting in 1st grade, and before reaching 4th grade, 12 of their friends' parents have died. That's just an astonishing and deeply disturbing statistic. And for me, I'm in my 30s. I was someone who grew up as this was really taking off. And I've lost friends, sports teammates. Someone featured on my campaign literature for my 2016 campaign passed away 2 years ago from an overdose. So I know we all have our own personal stories, but certainly people in this town have been deeply, deeply impacted. And it's gotten worse. I'm sure it's been mentioned earlier during the day that through COVID, we've seen an uptick. The lockdowns and social distancing practices, while really necessary, of course, also led to this deep isolation that I think we all experienced and all went through some mental health trauma over the past year. And unfortunately, part of the lockdowns decreased access to services to help people cope. And I think some people turn to opioids as a potential coping mechanism to get through the loss of the pandemic. And on top of that, our public health system faced just extraordinary pressures, just overwhelmed at points with grappling single-mindedly on one pandemic while diverting resources from this epidemic. that we still face. And we saw that at Gosnell Treatment Center, right, where there was a heavy increase in demand for beds over the past year, and made it really difficult for people to get the demand made it difficult for people to get the treatment that they needed. And while the pandemic straining our healthcare systems, overdoses increased by about 18% from 2019 to 2020. And Falmouth followed this trend over the same period. We saw around a 20% increase in overdoses, and deaths from these overdoses also substantially increased, up 5% over the year-long period. And of course, thinking from a Cape and Islands lens, but also a statewide lens, these deaths haven't been equitable, if that's a proper term, and haven't been, they've impacted different groups differently. Communities of color saw significantly higher increases in fatalities. And in 2020, for Black males, opioid-related overdose deaths increased by 69% over 2019 levels. So you see, within the data, you see some really troubling trends around racial equity as well. And the increased deaths over the past year are really particularly alarming. Obviously, we, through 2016 to 2018 statewide, we saw a decline. I think a lot of this was in part because of legislation that was passed to really make the use of Narcan widely available, and to drop that cost of Narcan. And so I think that really heavily impacted the lower death rates. But of course, this isn't just about opioid deaths and overdoses. There's also these really nefarious secondary impacts around needle sharing. And so we've seen a huge spike in hepatitis C and HIV that have just skyrocketed pre-pandemic and have gotten worse during the pandemic. Roughly 9,000 people each year are diagnosed with HCV, and over 20,000 people in Massachusetts are currently living with HIV. And these rates, are only climbing. And so we are, as a state, spending a lot of resources to try to address this. First of all, the epidemic, the opioid epidemic costs our state about $15 billion a year. That's a recent analysis that came out a couple of years ago. And in a secondary study, the Massachusetts Taxpayers Foundation found that in our $48 billion budget, $2 billion of taxpayer money goes directly towards addressing the opioid epidemic on a yearly basis. So $2 billion is a significant sum. But after $2 billion spent on an annual basis, we only see a tiny reduction in opioid deaths. And I think a lot of people agree that's largely attributed to Narcan. So I think, we need to take a really close look on how the state is spending these dollars. And I think we need to do a lot more on harm reduction. And yes, of course, we definitely need more beds. There's no question. We need more treatment. We need our insurance to cover treatment longer, but we also need to look, I think, at the entire person and also get at the root causes of addiction. I think a large part of this is about giving people economic security. Other countries have put forward jobs programs to help give people, more kind of meaning in their life. And I also think we need to create a more vibrant place for Cape and Islanders with more activities and economic opportunities for young people here. And, for those suffering from this disease, who are suffering from substance misuse, we need to do everything in our power to keep them alive. And I believe that includes giving them a safe place to use safely where they can, get treatment if they're where they can be revived from an overdose, and where also they can be sent to treatment as well. And so for anyone addicted to this morphine molecule, there's still hope for recovery, and we cannot allow the stigma around this disease to prevent people from getting the care that they need. So, I'll stop there, but I'm really excited to hear from my colleagues and get into some more issues around the state that we've been taking up. So thank you.
Thanks, João, for leading us into really a picture of a lot of what we're seeing here, and the change is really when those numbers came out a few weeks ago. Not just the increase, but the change in the demographic is really mind-boggling to me. Increasing the number, yes. I'm very interested to learn and to hear from anyone in this panel, Barbara or others, that might be able to tell us what the shift was versus just the increase. I can understand the increase, the isolation and all of that, but that real demographic shift jumped off the page of the report to me a few weeks ago, and that's something that we need to really double down on as we head forward. One of the things that I've worked a lot on over the last few years is dealing with this crisis as it relates to those incarcerated, and in a couple of ways. One is working to allow medical assisted treatment in our correctional facilities. We had a few pilot programs. Barnstable County was one of the first to use Vivitrol and still using Vivitrol. However, Barnstable County is only using Vivitrol, and that is becoming an issue now, and also potentially a legal issue around civil rights by not having access to Suboxone and the methadone. So we've been working this year to try to include Barnstable County and some other counties in the statewide pilot that allows multiple medical assisted treatments in correctional facilities. We fund a $15 million line item right now for that treatment in correctional facilities in the Commonwealth, but we only allow 6, I believe, or 7 of the counties to participate. And so we've begun through the budget process this year having conversations of how do we expand the program to all of our correctional facilities, but also how do we allow the other options for medical assistance to happen in the correctional facilities. One of the big issues with that is those programs tend to tie in Barnstable County to our RSAP program, our Residential Substance Abuse Treatment Program, that's in a special pod in the facility. And it's in the facility under the area and jurisdiction where inmates are. And there's an old 1920 statute that did not allow pretrial detainees to be housed in the same housing units as convicted inmates. And so we would have folks that could be held pre-trial for up to a year that would want to participate in these programs and would benefit from these programs, and were not allowed in the facility. And so 2 years ago, we changed that. We changed the statute to allow, in these cases, for residential substance abuse treatment, the pretrial detainees to be in the same housing unit with convicted inmates. However, in the evenings, they do have separate cells, and if there's a lockdown, they're locked down in separate cells. But the facilities weren't able to run 2 RSAP programs with a small population of pretrial detainees, and another one for those that were in longer-term incarceration. So we were able to change that. Thinking about the long term, and I'm going to step a little bit on Dylan's toes on his district, but one of the things that is really exciting to me about the long-term treatment and research is the work that's being done in Woods Hole at the Marine Biological Laboratory. I'm a regular member of the bonding committee in the House, and we've been working with MBL and got them some state bonds which are being released to expand the development of their 3D imaging laboratory. And our first panel today, we had our colleagues from Portugal. We are actually bringing in cuttlefish from the Azores to do some of this research on. And MBL is trying to invest in developing the imaging technology to get to the actual level of each synapses in the brain, not just the areas of the brain that are activated and stimulated by emotions, by drugs, but to be able to get to a point where there can be an intervention at the synapses level to cut desire, to cut addiction. And we don't have the technology yet to see that. But the big folks in Dillon's district are working on that, and as the state, through the Mass Tech Collaborative and through our bond issues, we're investing in that. And it's not going to help families right today. We need to work on interventions, treatment, harm reduction today. We've heard a lot about that over the course of this afternoon. But we also have to look longer term and figure out how do we deal with the Band-Aids today, and how do we look at the horizon of how we can end the future of these types of addictions. And lastly, because I know we have a lot of panelists on this section, lastly, I want to say that today, for most of the day, a new member of the Falmouth Board of Selectmen joined us, Anjali Scott Price, and she, when she was running, was meeting with me, talking about the opioid crisis and what was going on, and I told her about the session today, and so she has participated. But Anjali is also an individual who, for the first time in decades, will be able to open up a line of communication between our municipal government and our minority populations in town. And so my hat is off to her for her election. My hat is off to her for her participation today, and for the work that she can help us do in connecting with those populations that we're finding in the most recent data are being impacted at a greater level than ever before from this crisis.
We'll pass it back to Tracy and Tammy for Q&A now for the rest of on this session.
Thank you so much, Representative. Yeah, thank you all, and for very different perspectives and an opportunity to think about what we might be able to do to address some of the suffering in Falmouth and across the state. I would love to invite Tammy to share a little bit more on both her work and her initiatives, and I think maybe would be able to give us some insight into some paths forward and maybe some changes that might be opportunities to have a different story, a different outcome for some of our Massachusetts residents.
Yeah, I just want to start by thanking Miguel for inviting me here, and thank you to my colleagues for welcoming me to the Falmouth Forum as well on opioids. I want to especially thank you, Barbara, for sharing your story. I think as Rep. Fernandez said, so many of us have our own stories, whether in our family or in our communities. I am a public health social worker by training. I have been doing that for the last 25 years prior to getting elected into the legislature. And in part, the reason I think I was drawn to social work and to addiction prevention and addiction treatment is because as a young child, I watched and accompanied my mom in taking my grandfather to detox over and over again. And so I sympathize and feel some of the early trauma of what that's like to support a family member in their own journey. And this was a long time ago. We're talking almost 40 years ago. And, the treatment modalities have definitely improved and changed. But Barbara, I heard you say maybe about an hour and a half ago or so that, we've done a lot of great things, but we're going way too slow for where we really need to be to alleviate the suffering. And I just want to focus in a little bit on children for a few minutes and then address a question that Rep. Vieira brought up when he spoke. So one of the reports that just came out of the Office of the Child Advocate is around children in the custody of the Department of Children and Families. And there were 500 critical incidences that were reported. And of those, 200 were a child witnessing an overdose of a parent in the state of Massachusetts. And this is just in a 1-year period. There's definitely been some improvements in the reporting that's probably contributing to some of the increases. But we certainly know that the impact of COVID-19 has been really tremendous and traumatic for our young people. And we also know that there's like the twin issues also with mental illness, whether it's diagnosed or undiagnosed, and the lack of an ability to get treatment, particularly during COVID. And that's certainly the case in particular for our rural communities that don't always have the access that they need. And then also tied with domestic violence as well. So, we had this real braiding of a lot of different issues happening simultaneously that's contributed to these overdoses that our children have witnessed. 30 of them were fatal. So that means most of the parents luckily survived the overdose. And the hope is that, there can be, continued care and support given to these families who have been struggling with addiction, particularly through COVID. David, you asked earlier about, why the recent increases and changes in the demographics. The shift in demographics have actually been going on starting in 2014. We just weren't paying attention to it. And I think a lot of that is driven by the fact that for so many of our communities across the state, parents are losing their children, and the parents who have greater access to legislators and the ones who have access to resources to really shine a spotlight on the issue of addiction, particularly when it comes to opioid overdoses, are quite honestly white families, white middle class, upper class families. And so I do think this is all coming from my research from my doctorate, which I defended last year, where I focused on the political feasibility of non-arrest policies for opioid use and addiction in the state. And this was the thing that really jumped out at me, just like it's jumping out at many of us here, is just how the demographics have been shifting. And our conversation hasn't really focused on this changing demographic. But if you talk to healthcare providers who work with families of color, Hispanic and Black families in particular, they've known that this has been going on, and they've been trying to get policymakers and get people to, pay attention a little bit more and make those investments. And part of the other part of my research in talking with police officers and treatment providers and other policymakers is that there's a real need to have community-based local access to community resources. And I think, Rep. Fernandez, you talked about this a little bit. It's like, what are the root causes of addiction? But it's also, what are those things that we need to invest in to support people in achieving recovery and, around housing, transportation, and just making sure that access is really local. So I want to thank Rep. Fernandez. Last session we filed, he was the lead on safe consumption sites. That bill has been filed again this year. There's been a lot of efforts in the legislature around access to Narcan. I filed legislation to create a pilot project around fentanyl test strips, which we know is a harm reduction strategy to allow people who are struggling with addiction to opioids, in particular, to test for the presence of fentanyl and perhaps make a different choice. There is some emerging evidence that people who are using opioids, who do test for the presence of fentanyl, do make different choices if fentanyl is present. And then in the last session, I advocated to have the bill that I had filed and the funding to DPH to also include a focus on not just people who use opioids, but also people who use cocaine and other substances. And that's the thing that I suspect is kind of is probably contributing to the shifting demographics, is that our communities of color, our men of color in particular, are not always using opioids, but there's polysubstance use, and there's probably fentanyl and a whole host of substances. And we know that there are a lot of people who present at the ER who say, I was just using cocaine, and they show up and they've had an overdose because there's been fentanyl found in their substance that they've been using. So I think there's a lot more for us to do in this space, but I think it's just really encouraging the move towards harm reduction, the move towards the demand for more treatment. And that's the thing that did come up over and over again in my research, is that there's just a lack of access to treatment for communities of color in particular, as well as, of course, our rural communities. And I know Gosnell is an amazing resource and center, so you're really lucky in your area, but just other parts of the state are really continue to suffer. So I do think there's a lot more for us to do. I did look at the political feasibility of decriminalization. I was able to do some research in Portugal just a year before COVID hit to really learn about the system that is in place in Portugal and what might we be able to model here in Massachusetts. I even talked to, more conservative policymakers who said, decriminalization is probably a good idea, but we have to be really careful about how we do it and making sure that we're not sending the message to young people that using substances is an okay thing. And I think there's a lot for us to learn from, the various commissions that have been set up in Portugal to make sure that people are getting access to treatment and getting identified early for substance misuse that's on the pathway to addiction. So those are just some of the few things that I wanted to share. I really appreciate being here and being able to talk about this really important issue, because we know that we're going to be suffering the consequences of the impacts of COVID on the rising rates and the rising overdose for quite some time.
Wonderful. Thank you. Thank you so much, Tammy. A wealth of knowledge and a wealth of action in Massachusetts. Thank you for your amazing contributions and the continuing conversation about different approaches and different policies. I'm wondering if you might be able to speak to some of the changes that happened during COVID-19. In particular, I'm thinking about, we heard from Dr. Goulão about some really progressive things that sort of happened during this pandemic, keep on doing some additional harm reduction activity, expansion of medication, looking for fentanyl in the drug supply, expanding access to methadone in low barrier and mobile methadone environments, working to really reinforce the cities to do more in their municipal sites on harm reduction and other, kind of real focus on the drug supply, but also engaging people in of course, socially distanced and safe ways. But here in the States, I'm wondering in Massachusetts, we did quite a lot there, not quite as in the same Portuguese model and style, but some of the things I have seen, we've been arresting a lot less. We've been releasing prisoners. We've been continuing medications through 24-hour hotlines, through BMC and otherwise. We've been loosening up our restrictions, our hold on starting people on medication and continuing people on medication, sending people with take homes, and really flooding, if you will, the community as much as possible with naloxone and other harm reduction tools, as we heard from Dan Gates and others at ASGCC, syringe access, wound care kits, connecting with outreach and other, even law enforcement doing kind of remote outreach. What of these things should we just keep doing? And what are the kind of resources and opportunities to both kind of adopt that as a model and keep it up? Or should we maybe keep the law and hold the line to allow this to continue in Massachusetts and other places? We've kind of had a loose, almost in some ways, decriminalization as it is. What are your thoughts?
I mean, I'll jump in, on a bill that Tammy mentioned that we've been working on. And so we filed the bill around allowing a pilot program for safe consumption sites in Massachusetts. I mean, this really gets at the heart of harm reduction. So for folks who don't know, a safe consumption site is a place where someone who is addicted to any drug would be able to go in and use that drug under the surveillance of a medical professional who could then revive them from an overdose. There's hundreds of these around the world that have shown some really promising data. Our neighbors to the north have them in several of their cities in Canada. And we actually brought down the Minister of Health for the province of Quebec to the State House 2 years ago to give a presentation to the legislature around the efficacy and the life-saving that these sites have produced for them. So there's certainly a working model here. So we filed this bill. I filed it last session. It got reported out of committee favorably, which was a big step. And then the pandemic struck, and that took up a lot of the oxygen in the room. But we're hopeful about it this session as well. And so these sites have been proven to reduce overdose deaths, there's in the region that they're in, there's never been an overdose death in any of these sites ever. And they also have proven to help people get access to treatment, which is the real key. There's like a 25%, that's a couple of sites in Canada, there's a 25% increase in access to treatment for those who use them. And so it is really, really hard to get people suffering from substance misuse, and in some cases to get that access. And honestly, a lot of people aren't going to pursue it until they're willing to do it. And so providing a place for people to be repeatedly prompted to get into treatment, I think is a real positive. And at the end of the day, the thing that I care about, and I think we all care about deeply, is at the end of the day, I just want to save lives. I just want to prevent people from dying. And these have proven to be able to do that. I think the only thing holding us back from this, again, this is in Canada, almost every Western European nation, Australia. I think, one of the main things holding us back from doing this is just stigma of that we see with people thinking that it enables in some way or sustains people's habit. And I think one of the most important things we can do is to save people is to push back around that stigma, because it only perpetuates harm. So this is something I'm really hopeful of. Tracy, you mentioned a whole host of other programs. I'm also very supportive of. I would love to see the state take a really hard look at decriminalization. I would support it. I personally think that anyone who is suffering from addiction should not be charged as a criminal for that substance misuse issue. We've seen this kind of play out in some other states that have gone a little farther than us. So I don't know. There's bills filed on that in the legislature this session. Senator Sear filed the Senate version. I'm blanking on who filed the House version, but that's certainly an ongoing discussion right now in the legislature. Do I think it'll pass this year? I would be very surprised. I think this is going to require a really robust public debate, and I think that's why it's important we're here right now.
Just to jump in really, really briefly, everything that you listed, I do hope we continue those, because I do think that they move us in the direction, they would be supportive towards the direction of decriminalization, but they are squarely for me in the space of being a more humane approach to people who are experiencing addiction. The other thing that I would hope that we would do a lot more around, and this has been somewhat of an active conversation in the State House, I think we need to activate it even more, is around how to address trauma. And how do we be not just trauma informed, but trauma responsive across all of our systems. So whether you're talking about the medical care system, or you're talking about local public health, or you're talking about the school environment, just really more professionals just understand who interface with young people, who interface with families, having them just understand how people might be presenting with different forms of trauma, because if they're not supported, then they are more likely to engage in other coping mechanisms and other, putting them onto a path of addiction. And we know that, if a child who grows up with addiction in the household or mental health issues in the household are also much more likely to engage in addictive behaviors as they grow up. So just as a society, really having a lot more of a wraparound approach to how we're supporting people who are experiencing trauma. And I really just see that fitting in with, so many more people are talking about mental health because of COVID. And I think that there's been a real recognition that it's been an ongoing problem, and there is reduced stigma around mental health as a result of COVID. So I think there is an opportunity for us to move things in a different direction and destigmatize these things that have been stigmatized in the past. Oh, and I think it's Rep. Connolly who filed decrim on the House side.
Picking up on what Representative Govea said about the trauma-informed, particularly in the schools, there's been a program around for a number of years. We actually ran some of the pilot development on the Cape called the Safe and Supportive Schools Model. And when we were talking about trauma-informed education, and we couldn't get the bill passed. We couldn't get funding for it. And in 2016, when we did our massive firearms update law, I contacted the folks from the coalition that's organized out of Harvard Medical School, Ann Eisner and the crew, and said, hey, let's talk to the speaker about putting safe and supportive schools in this gun bill, because everyone's talking about dealing with these mental health issues in schools as it relates to school shootings. And while, yes, it might address that as well, we've been trying to push this initiative for 4 years and nobody's listening to us. And lo and behold, we were able to get it in there, in the bill. And now we've also been able to expand the funding each year with the grant funding that goes back to the schools. But that's only in the school environment. And so when we talk about funding, my concern at the beginning of the conversation of decriminalization or the safe sites that Dylan talks about is if there is a 25% success rate in some of those areas of getting people into treatment, do we have those beds available? We have not seen the appetite to really make a public investment in expanding these treatment options. And we need to do that. And Barbara was talking about Bridgewater earlier. We've got these hospitals that were our mental health hospitals around the Commonwealth. And I keep saying, why don't we buddy up with a bond and turn the lights back on and make these facilities treatment facilities? And whether or not we go and we force every insurance company to cover the full amount of treatment, or we find another way to be able to subsidize the treatment itself, we've got these buildings whose roofs are ready to rot in. They were built as hospitals in our mental health system. And so I'm really upset, have been for a number of years, that we cannot find the willpower in a $40 billion budget to put real investment in treatment. And so if we create other feeder lines to treatment or transform, like Portugal did, the system of how individuals are interfaced with, we got to be ready to put the money up. We got to be ready to have the beds, and we got to be ready to have the clinicians to do it. And so I think it's a parallel track as we talk about those. We really need to start looking at, are we going to make the investment, or are we going to raise that level of expectation, and then our offices continue to get the calls to say, I can't find a place for my husband, my brother, my wife. I'll give you one specific example. My office, my district office, is within a mile of Gosnold. And on a Friday afternoon at about 4:30, a few summers ago, a woman came, knocked on the door, didn't have an appointment, and she came in crying. My aide calmed her down, came into my office and said, there's an individual out here, she wants to talk to you about her husband, he's at Gosnold. So I came out and I talked to her. He went through his, quote, detox period. And he went up there, and he wasn't even high when he went up there, but he went up there because he had to do that in order to get his placement 5 days later in a long-term treatment bed. The Commonwealth, for some reason, screwed up his mass health insurance over the period of time that he was making this scheduled transition. And he was released from Gosnold, and he was sitting in the lobby waiting for his wife to pick him up. And she said, if I pick him up, I believe that he will kill himself this week, that he will overdose, that he will kill himself if he doesn't get into the treatment. Because the bed wasn't available. And we were able to, luckily, make an emergency patch through Cape Cod Healthcare, put him in the emergency room down in Hyannis, transfer him to the Cape Psych Center. They did a short-term 3-day hold so that we could get the Commonwealth to fix the screw-up they did on the insurance so that somebody was willing to make the bed available so that they'd get paid. Those types of stories were just, one incident that I had to deal with personally, and I can only imagine how many folks didn't know where their rep's office was, didn't know who to call when the insurance didn't come through, or when they're looking for the bed and the bed's not available, right? So we really need to make that investment in the infrastructure, and then I'm more than willing to continue the conversation of the feeder lines But my concern right now is we don't have places to put them under the existing feeder lines, and that makes me nervous.
Yeah, thank you for those thoughts and sharing a really tough story. It's not a rare story to share, though, unfortunately. And we have a lot of missed opportunities, and transitions are extremely vulnerable times, leaving incarceration, leaving hospital, transitions in care and continuity of care are a place where we have a lot more that we can do. And we, with technology and so many opportunities in Massachusetts and other states, there seems like a real growth opportunity for all of us to do better for a disease that is ultimately treatable, preventable. And I'm thinking to Dr. Goulão's comments earlier this morning, and also a year ago when he was in Rhode Island and shared with us a lot about his country's approach to addiction. And we asked him a lot about stigma and how stigma of addiction was addressed culturally and how different it was. It stuck out as such a contrast. And I really appreciated his reflections on that the more it was normalized, the more that we remove the criminalization of drugs, the unraveling of the stigma, the cultural shift that occurred, and a more socialized approach to and more empathetic, as well as a more productive approach to treating people with respect and addressing their health problems. And in doing that, healing the community. A real recognition of trauma and some of those root causes, allowing people to really seek care instead of having to hide or be in isolation or be afraid to ask for help. That someone, when they call 911, they're going to be visited by a post-overdose outreach team that's also going to section them. Like these kinds of things erode trust and recognize that we have an opportunity to do better and to peel stigma back. There are many, many layers, but the ultimate outside layer is that legal piece, that criminal piece, that the part that has made mental health criminalized for a long time as well. But we're making great progress. There's a lot more to be done on that. And then the other thing I remember hearing quite a lot about was by embracing and destigmatizing and decriminalizing, allowing really treatment to be everywhere. That there was multiple touches and multiple opportunities. So community health centers, community mental health centers, that judges pointed to the same place as the doctors, pointed to the same place as the outreach workers, where everyone was pointing to the same sort of supportive network, so that everybody could watch out. I've actually seen this in action on the Cape. It's worked for Cape Cod, I'm sorry, not anywhere, but I've watched this happen in some of their peer navigation. We've evaluated their peer navigation approach and work with Duffy, and it has been amazing watching during COVID that while one person's out talking with folks in the encampment, another person is calling in the medicine, another person is making the appointment and connecting. So when they see someone walking around, they're like, oh, I just saw so-and-so. I gave them a whole bunch more Narcan, and they give them more Narcan. They give them 50 Narcans, not 5. They give them as much as needed. And they follow up, and then this continued network of care, there are these points of light to really show that care that's destigmatized, that is trauma aware, and that is always there can keep people alive a lot longer. And it's in the long run less expensive and more of an investment in our future.
Can I just add something to that? Just in terms of stigma, just going back, I forget who it was earlier today, it might have been Jody, who said, we've had a criminalized approach to addiction and substance use going back 100 years. It's actually been 200 years, and it was really driven by racism. And so I firmly believe that in order to detangle a lot of the stigma around addiction, we have to face the fact that our policies came out of racism against particularly Chinese men. And the first ones were around opioids. And it was also steeped in sexism because there were white women who were spending time with Chinese men. And it was like, well, we got to protect the white women from fill in all of the really horrific racist things that were being said in order to pass really stringent opioid policies. And then we've just, for a very long time, made those policies more and more stringent, more and more punitive. We've had periods certainly where, we've moved towards decriminalizing, but again, you all know the story with Nixon and Reagan and everything else, and just like really what we've been living with since then. And we've been slowly, even in this state, undoing a lot of that with eliminating a lot of the mandatory minimum sentences around possession and et cetera, et cetera. In the 1970s, we decriminalized public intoxication, and it actually drove the need for detox centers. That's where we got a lot more treatment centers in the state back in the 70s, was in response to the fact that we had decriminalized alcoholism or public drunkenness, and police officers needed a place to take people because they could no longer take them to jail for being drunk. So I think there's just a lot of different levers to push here to move towards getting more treatment. But I firmly believe that there's some nuggets that we have to undo that relate to what drove us to pass these punitive policies in the first place.
Well, this has been a wonderful reflection and an amazing couple sessions, Miguel. We're coming upon the 6 o'clock hour, so we're going to close our fantastic panel. Thank you all for your thoughts, and Barbara, thank you especially for your story. And we will look forward to continuing the conversation after this session. I'll turn it back to you, Miguel.
Great. Thank you so much, Tracy, and also to the representatives and especially Barbara also for her presentation. I'd like to thank really all of you for coming here today, including the attendees, all of the panelists that spoke. It's been really a unique opportunity to hear from so many people that do such great work, that are really doing the hard work necessary to try and help people. And you all should really be commended for that and thanked for that. And also for talking about that so openly with all of us in a way that really helps us to come to a better understanding of this issue. This is a very complex issue, as almost everyone has said, either directly or indirectly throughout the entire afternoon. And there are no easy solutions to any of this. What we have both behind us and in front of us are lots of hard conversations and lots of collaborative efforts to try and get the science out there, get the best practices out there, and start to help people to change minds. And I really just thank all of you, and greatly appreciative to all of you for helping to accomplish that in no small measure today. So thank you very much. I'd like to also thank
for hosting. This has been fabulous, and Tracy and Barbara and my colleagues. It's been a really powerful discussion. So thank you.
Good. Thanks, Representative Fernandez. I'd also like to thank today our sponsoring organizations, including the Cape Cod Cape Verde Museum and Cultural Center. Barbara is the curator of the museum and really the founder and the heartbeat behind the museum. I'm going to put in a plug for June 25th will be the grand opening of the museum. So we hope that you all will come out for that. There's going to be some incredible exhibits, including exhibits from all the organizations that were here represented. That includes the Cape Verdean Club, also a sponsor. Thank you, Corey, and the Portuguese American Association as well. And also includes other community organizations in Falmouth, Portuguese and Cape Verdean organizations on June 25th. So please come out to that, as well as to the COBRE on opioids and overdose, which is really an extraordinary center of study, of research, and a place that has just done an incredible job of trying to bring together and bridge all of these, these many different people that come together. There have been so many organizations that COBRE works with, so many unique projects. I think there have been about 16 projects right now, both past and current, that COBRE has been responsible for, in addition to other collaborations, doing really innovative work. I think of like Rhode Island Cares, for example, who's doing some really interesting exhibits on overdose prevention sites, and as well as many others. So, the COBRE, if you haven't gone to that site, please go to it and check out the great work that they do. And thank you all for coming this afternoon. This is one conversation that took place in a series of many, many other conversations, and it definitely won't be the last. So I look forward to hearing from all of you again in upcoming weeks, months, and years. So thank you all.
Thanks, Miguel.